today. Some of them are continuations of the anatomy we saw yesterday. Other are clinical surgical applications. So the first lecture will be given by Professor Pablo González López from Alicante, Spain, on the optical radiations, anterior commissure, and applications to epilepsy surgery and ventricular approaches. Thank you, Pablo.
Buenos días. So this is going to be a kind of continuation of what we were reviewing yesterday, not only here but also in the lab. And as you will see, the optic radiations and the anterior commissure are located in the lateral aspect of the hemisphere. So just below the IFOF, which is the first structure we were discussing yesterday with Ailis here, and we tried to dissect it in the lab. Once we peel it away, we will uncover the next layer, which is based on the anterior commissure and the optic radiations. And I'm going to try, as always, to give a clinical point of view in order to understand why it's important to know the location of these structures. So this is the review, again, to reinforce how the central nervous system is classified. Yesterday we were mainly discussing about the association, long association fiber systems, but today we are going to concentrate mostly on the commissural fibers, mainly anterior commissure. Later on, Professor Roy from Lausanne will discuss also the other commissural fiber systems and also the projection fiber systems, because as I will show you, the optic radiations are a very important part of the internal capsule and are projection systems going from the thalamus to the cortex. So again, this is the general organization of the gyri. The main fibers we are going to discuss today are arising from the central part of every single gyri, and this is the anterior commissure, and these are the optic radiations, which are the structures we are going to discuss right now. So I like to start always with a quiz, and let me know if you remember this structure we discussed yesterday. This is a part of the tract I have cut here, and tell me the name of that tract. We saw it yesterday in the lab and here. Don't be shy. I cannot see you. What's the name of this tract? I can hear you, yeah. SLF or arcuate. This is the long association fiber system, SLF, the arcuate system. And we have cut it here so as to show the corona radiata, these projections, which join together here in the superior aspect of the putamen, which has been removed. So they join together the external and the internal capsule to form this corona radiata. Here we have the anterior commissure. This is the posterior part of the internal capsule, and finally the optic radiations. So this is the dissection we did yesterday, SLF and arcuate. We go deeper, we cut the operculi, so we have the insular anatomy right there. We started peeling away the cortex to expose the extreme capsule. Next layer is the external capsule with the IFOF. We will discover it today in the lab. And if we cut a little bit and we create these windows in the external capsule, we can see this gray matter, which is which nucleus is this one? Putamen, perfect. So once we remove completely the external capsule, we have this view of the corona radiata, putamen, all the projections of the internal capsule, and the IFOF. And this is the area of interest we are going to deal with today. The anterior commissure and the optic radiation fibers are right there. And in this picture, I prepared this picture 2 weeks ago to show you the sagittal stratum. The sagittal stratum is a structure which is composed of mainly 3 fiber systems, one commissural, one association, and one projection fiber system. So the first layer we have is the long association fiber system, which is the IFOF, right there. Below it, we have a commissural fiber system, which is the anterior commissure, and deeper, we have the optic radiation. So these 3 layers, in fact, they are not so clear in the lab because they are intermingling between each other, but from the surface to the depth, we have IFOF, anterior commissure, and optic radiations, and I will show you right now. So this is the lateral aspect, the most superficial aspect of the sagittal stratum with the IFOF. We remove the IFOF, and we have this anterior commissure. You can see how the anterior commissure is going posteriorly and going directly to the temporovasal and occipital lobes. And as we will see later on, it has also a paleopallial connection to the amygdala and the temporomesial structures. We will cut the anterior commissure right there, and we will try to peel away all its fibers, and then the next layer will appear. After cutting and removing it, we have these optic radiations with Meyer's loop coming from this is the optic tract, lateral geniculate nucleus, and the optic radiations. So you can see how these three different fiber systems are arranged in this nice way, covering the lateral aspect of the temporal horn and the atrium of the ventricle, as we will see later on. This is a phylogenetic study slide. It's quite a tough slide, but it's interesting to know that the anterior commissure is the oldest commissural fiber system in phylogenetic terms. In fact, 500 million years ago, the fishes developed a very rudimentary central nervous system, and the main commissural fiber system between both rhinencephali was the anterior commissure, and this is kept nowadays. What has happened with the evolution is that we have created and we have developed a very complex neocortex and paleocortex and archicortex, sorry, and we have now different and much more evolutioned commissural fiber systems as the corpus callosum. But the fishes still keep this one. And we can have a nice idea of all these phylogenetic terms, all this phylogenetic evolution with embryology. So in the first terms of the embryology, the anterior commissure is the first commissural fiber system appearing. So this is the one we are going to discuss. And finally, once we develop the most complex commissural fiber systems, we have in our brains, the humans, we all have these three commissural systems. The corpus callosum, which is the most important one, which is exclusive of placental mammals. We have also a hippocampal commissure, which is quite rudimentary. And we have also all the vertebrates, we have the anterior commissure. It's the so-called paleocommissure. And this paleocommissure, the anterior commissure in humans, it's not very well studied. We don't have a very good idea about its functions, but mainly is related with limbic functions as visual, verbal, and non-verbal memory processing. So this is, as we said before, the most important commissural fiber system that all the fishes have. And if we have a look at the central nervous system of a single fish, we will see a very thick and very well-developed anterior commissure joining the rhinencephalum on both sides. So memoristic functions, olfactory sense, and reaction. The most important thing is reaction to fear and danger. So this fish was alive, and they were going to take a picture of him, and the first thing he did, once he realized that he could escape, was escaping. So this is mainly due to the amygdala. They are working. He perceived a damage, a danger, and he decided to escape very easily thanks to the anterior commissure. We are very lucky. We have developed a very complex neocortical layer, and this neocortex is joined through the corpus callosum. So we have not only this reaction to danger and fear, but we have also many other functions. So this guy is prepared to rob a bank, and he's going to take the gun, and you saw what happened. The commissural fiber system didn't work properly, but the anterior commissure worked really well. So we can have very well developed functions, but always we have the anterior commissure as a reaction to fear and damage. So let's go to the study, the anatomical study of this anterior commissure. This is a view from below in which you can see how it's centered in the basal aspect of the hemisphere and is connecting mainly the temporo-occipital regions on both sides, and also, as we will see right now, it has some connections to the temporomesial regions, which are the important ones in phylogenetic terms. So it has been described as a bicycle handlebar, because if you see in this tractography, it has the same shape of this bike handlebar. So in all the MRIs, we can see the anterior commissure just in the ventral aspect of the basal ganglia. This is the anterior commissure, which is crossing the anterior wall of the third ventricle, as we will see later on, and it has some temporomesial connections to the olfactory region mainly, and also the neocortical connections, which are very well developed in human primates. Well, let's study the mid-sagittal view of the anterior commissure. This is a dissection. This is a beautiful drawing from Nieuwenhuis' book, which is wonderful for all these deep structures. And in the center of all these mesolimbic structures, we have the anterior commissure. The anterior commissure is well connected to the stria terminalis, which is a very old limbic belt connecting the amygdala together with the septal region, peripharyngeal region, and also with the anterior commissure. So all these deep limbic belts are connected, and the anterior commissure is a central pivotal point for them. Let's have a view from basal, and here we can see the anterior commissure and its deep and old connections to the septal area and to the amygdala, and finally we can have also have an understanding of the neocortical connections. So the anterior limb of the anterior commissure is connecting amygdala regions, anterior perforated substance, and the septal region together, and the posterior limb is mainly communicating or joining together the temporo-occipital regions on both sides. This is a mid-sagittal cut, a sagittal slice of the right hemisphere, and this is an inferior view from the frontovasal aspect. This is the gyrus rectus. So here I have dissected a little bit the septal region. So this is the septal region, the amygdala is right there, and we can see how the anterior commissure, this part, this anterior limb of anterior commissure is not easily to be dissected because in most of us is very, very, very thin, but we were lacking this specimen. We had a very thick anterior limb of internal capsule, so you can see this branch, how it's connecting the septal regions in both sides. And then this tract is going more laterally, and this is a superior view of another specimen in which I was able to dissect again not only the main part of the anterior commissure. So this is an axial slice like this one in which the putamen and globus pallidus have been removed. So here we have both frontal horns, both fornices, and the anterior commissure in the ventral aspect of the basal ganglia. And you can see these very, very thin fibers. They are connecting both amygdala. So these fibers, the septal region and the amygdalar ones, are connecting the temporomesial structures, the old structures in phylogenetic terms. Let's go lateral. This is the same dissection, but from a lateral view. So this was the bed of the putamen. This is the right hemisphere. This is the optic tract to get a good orientation. The putamen and globus pallidus have been removed. So this is the whole internal capsule, anterior limb, genu, posterior limb, and the retronasal ventricular components. Which is this fiber tract, which has been cut here? This is the anterior commissure, perfect. So if we cut and elevate the anterior commissure, we can see this very, very thin band of fibers which are going directly to this structure. This is the amygdala, and this is the so-called diagonal band of Broca, which is just deep to the anterior commissure. So if we cut and elevate the anterior commissure, and we are lucky with the microscope, we can even see this very thin fiber system, which is the diagonal band of Broca, mainly amygdalofugal fibers, connecting the amygdala with the septal region, as you can see there. Let's go to the neocortical component of the anterior commissure, and this is the one we will see today in the lab. So you can see how it's coming from the midline, crossing the basal ganglia ventrally, and then expanding posterolaterally to the temporal and occipital lobes. This is another view of the anterior commissure. We have to cut it here, as we said before, and we will uncover later on the optic radiations. I want to show you here the close relationship between the amygdala, this is the amygdala, lumen insula, anterior perforated substance, and the anterior commissure. So here, from up to down, we have the caudate nucleus, the internal capsule, which has been cut there, and you can see this stria, these very, very thin bridges of gray matter connecting the putamen with the caudate. And in between these two nuclei, we have the internal capsule. So ventrally, anterior commissure with some optic radiations, amygdala, and once we cut the anterior commissure, we have a very clear view of the Meyer's loop and the optic radiations. Posteriorly, we have the tapetum, which is a part of the splenium, which is the most deepest layer in this sagittal stratum, covering the lateral wall of the atrium. And I want you to see the close relationship between all these structures: anterior commissure, Meyer's loop, amygdala, and the head of the hippocampus, which is inside the ventricle. Just the ankle recess, which is this recess here, separates the head of the hippocampus from the amygdala. So the so-called selective amygdalo-hypocampectomy consists on identifying the lumen insula, entering the cortex right there, removing the amygdala, and going inside the ventricle, trying to avoid the Meyer's loop in order to remove the hippocampus. Let's go to a practical case. Sorry, this is a 33-year-old guy who came with some scissors to the neurology department, and you can see this lesion right there. Where do you think this lesion is located? In the amygdala. Perfect. I was a little bit confused about if it was an amygdala or a hippocampal tumor, but if you go again to the correct, to the healthy hemisphere, you see the uncus here, and the anterior part is the amygdala, so the amygdala is right there, and the head of the hippocampus has been pushed posteriorly. So this is a temporal horn. This is a purely amygdalar tumor. And I don't know if you can perceive this thin layer. This is the anterior commissure. So the amygdala is superiorly related to the anterior commissure and the ventral aspect of the basal ganglia. Something curious about this guy is that he's a famous bullfighter in Spain, and I was discussing with Roy yesterday that maybe he was so brave because of this tumor, because he was a very, very brave guy. He had no fear to the bulls. So the tumor is located here. So we shouldn't remove the head of the hippocampus, and the limits of the amygdala are quite clear in the medial, anterior, and posterior aspects, but there is a dangerous area at this level. Here we don't have a clear anatomical limit, and we have here the anterior perforated substance with the lenticular striate arteries. So this is the most difficult limit, to identify this limit during this kind of surgery. And this is what we did, a diurnal approach. This is the frontal, this is the temporal, and we did a transplanum polare resection. So we always take some CSF to release and relax the brain. So we are opening the cisterns just to release CSF and identifying the planum polare. Once we identify it, we go directly to the amygdala. And once we reach this area, we can see the ankle recess here. This is the hippocampus, and this is the tumor. This is the amygdala with the tumor inside. So more or less, Meyer's loop should be right here. This is the area we don't have to damage, so we go anteriorly. And as we said, the limits are quite clear. We can identify the basal cisterns once we remove the anterior part of the uncus. This is what we are doing here. This is the spheroparietal sinus. So that's very clear, but the difficult limit is here. So whenever we are dealing with this region and we start watching a very, very thin bleeding, venous bleeding mainly, that's the moment in which we decide to stop, because it means that we are too deep. We are maybe reaching the lateral aspect of the anterior perforated substance. So this is the result, and you can see how the anterior commissure is right there. So we have just cut the ventral aspect of the basal ganglia, and this is the anterior commissure, which was a good limit in order to identify it in the MRI. So this is the post-op. So here you can see how we have reached this area, the ventral aspect of the putamen and globus pallidus. And the thing is that the patient did quite well. He had no more seizures, but he had a quadrant tanopia, as I will show you later on. So let's study this coronal slice of this left part. So here we can see the globus pallidus. We will dissect it in the lab. This is the putamen. This is the internal capsule. This is the head of the caudate, and in between them, you can see this stria of gray matter. We can also identify them here in this dissection. And the anterior commissure is just ventral to them, going lateral, just above the amygdala. So this is the most difficult part of the resection of this tumor, with the lenticular striate arteries right there. Post-op, we have already discussed it. And the tumor was located here, and if we are not careful, we can damage this anterior part of the optic radiation, which are going to give us this deficit. I insisted to this patient that he should never go back to his work, but after 3 years, he sent me this video because he was so in love with his job that he had to do it even with this deficit, which was quite dangerous. He told me that as bulls don't fly, he has no problem with the superior quadrant, so he is very happy now. I'm not so happy with him doing this, but it's his decision. Well, so let's continue. We have discussed the anterior part of the optic radiations with our Meyer's loop, and here I want to show you this picture to prove you that the Meyer's loop and optic radiations are a very important part of the internal capsule. So we have the very well-known anterior limb of the internal capsule, which is this one here. So this axial slice has been always done at this level. This way we can only see the anterior limb, the genu, and the posterior limb. But we must never forget two more components of the internal capsule, the retro and sublenticular components with the auditory and optic radiations, which are right there. From the medial aspect, the internal capsule has the so-called thalamic radiations. So in blue, we have a representation of the ascending fibers of internal capsule, which are going from the thalamus to some cortical areas, mainly through the anterior thalamic radiation to the prefrontal and cingulate cortices, and superior thalamic radiations going up to the postcentral region, and finally the auditory and optic radiations, which are a part of these thalamic peduncles. The optic radiations, this is the whole optic pathway. So we have the optic nerve, chiasm, optic tract, lateral geniculate, and you can see how the Meyer's loop arises from the lateral geniculate and runs posteriorly in order to try to find the calcarine fissure covering the lateral aspect of the atrium and the roof of the occipital horn. So this is also important in order to plan some surgeries like this. This is a meningioma in the atrium. It's located more or less here. And I was more or less sure that performing a transsulcal approach to the intraparietal sulcus, if we go quite medially, we could avoid damaging these fibers crossing the tapetum in the depth in the right side. So this is what we did, crossing this part of the tapetum. So this is the intraparietal sulcus, going deep, deep, deep through this sulcus, we reach the atrium. As you can see, it's a long distance, and all these fibers are being disrupted. This is one of the first cases I did when I arrived to my place, and I was quite confident with this, but unfortunately, this is what happened, because we damaged the most lateral part of these optic radiations. The patient is doing well, but this is quite uncomfortable for her life. Well, this is a scheme, general scheme of all the fibers, all the different damage we can cause doing this kind of surgeries, and this is what we damaged in the first surgery, and this is what we damaged in the second one. So we must be aware of the relative location of all these deep fibers if we want to keep a good condition for our patients. This is another case. This is a tumor which was not very clear with these axial and coronal slices. It seemed intraventricular, but if we pay careful attention at all the images, we will see that in fact it's an intrinsic tumor which is located in the isthmus. So different approaches have been described, but probably the most avoidable one should be to go through the shortest distance. Someone told me that the shortest distance between 2 points is the line, the straight line, but in this case, it's obvious we have to try to avoid it, because if we go through this sulcus, we are going to damage all these fibers. So these are all the approaches which can be done for this tumor. We can do a subtemporal, which is not a good idea here, because the Lavée, this is the vein of Lavée, is just in front of our surgical corridor. We can cross all these structures, but we will damage the optic radiations which are here. So this is why we decided to go through an interhemispheric approach, going directly to the isthmus and trying to respect all these lateral fibers with the IFOF, optic radiations, and the anterior commissure. So the tumor is here. We place the patient in this lateral position, and after releasing some CSF from the perisplenial cistern, we release and relax the brain. The splenium is going to be a good landmark to identify just below and posterior the isthmus. So this is the isthmus. We are going directly to the tumor, avoiding damaging the lateral aspect of the optic radiations. We start the debulking, and once we enter in the ventricle, we release more CSF, so the brain is much more relaxed. And this is the inner aspect. This is the tumor, inner aspect of the ventricle. So this is the lateral wall. These are our optic radiations, which are being preserved with this midline approach. Finally, this is the PET. This is the body of the lateral ventricle. This is the atrium with a pulvinar, and this is the temporal horn. So we respected not only the calcarine fissure, but also all the optic radiations going up there. This is one more case I want to show you, how we can even do some low-grade gliomas like this in the parahippocampal gyrus and invaded the cingulate. So probably it's very easy to go transcortical, and we will damage the whole optic pathways. So in this case, we decided to do a first approach and supracerebral tentorial approach to the parahippocampal region, and finally we completed it with a second approach in order to try to again respect as much as possible of these optic radiations. So we removed first of all this component with this supracerebral transtentorial. Again, we release CSF from the cisterna magna, and once the cerebellum is relaxed, we go inside. We measure where we have to do this cut in the tentorium, trying to preserve, if we can, these veins. If we cannot avoid it, we can coagulate them because they are quite lateral. We have a look always with the endoscope to get a good orientation. So this is the tumor in the tentorial incisura, but we have to go above, and this is the tumor itself. So this is the most difficult part of the surgery has been done. So we have approached directly to the parahippocampal region, and with this approach, we are respecting all the lateral optic radiations which are right here. So with the CUSA and the endoscope, this is the choroid plexus, this is the glomus of the choroid plexus. So all the optic radiations are lateral, we are respecting them. We are removing the most basal part, going to the amygdala all the way. optic radiations are there, and there we are going to the cingulate gyrus, but we couldn't go so superiorly. So this is why this is the resection in the first stage, but this tumor is still remaining. And again, we did a midline approach. In this case, we did a contralateral one. So we open the right hemisphere, which is the healthy one, and we identify the falx. This is the splenium. We cut the falx here. The brain is going down. So we can access directly the cingulate, posterior part of the cingulate gyrus. And this was a very fast procedure because most of the surgery was done. So we are trying to avoid damaging all these fibers. And let me show you the same anatomy from a different perspective. So these are all the optic radiations in the lateral wall. And luckily, the patient had only this deficit, probably due to the manipulation of the optic radiations at some point. So again, tumors inside the atrium should be approached in a way in which we think about the fibers we don't have to cross. And this is the last case I want to show you. It's an interesting one because you can see this tumor is located in the posterior part of the supramarginal gyrus, deep, reaching even the atrium. So all the fibers we have been discussing, IFOF, SLF, posterior part, vertical component of the arcuate, optic radiations, anterior commissure tapetum, all these fibers are involved on this tumor. This patient was operated. Previously, he had a biopsy because the surgeon thought that it was a GBM, high-grade glioma, but they were very surprised when it came with a pleomorphic xanthoastrocytoma. So we decided to do an awake procedure in order to try to identify the language and the optic structures. So these are all the fibers which are related to this tumor. So we must be aware of the language, mainly of the speech, and also of the visual aspect. This is the tapetum. I want to show you all the fibers. These are the optic radiations, this is the IFOF, and the complex of the arcuate. So all these fibers must be checked during surgery. And as we all know them, we decided to stimulate and to try to respect the speech and the visual functions. And this is why we prepare the patient in a sleep-awake sleep procedure. So this is how we display the OR. This is the neurophysiologist, these are the anesthesiologists, and we place the patient in a very comfortable position for that. With this case, we work with the bioengineering department, and they created a software for us in which they were able to perform an intraoperative campimetry, as I will show you. So in the first part of the procedure, we decided to map the speech. So he was identifying these different shapes, these different colors, and we were mapping the cortex. So with this task, he is able to understand, to speak, and to identify different shapes, and even to touch them. So this is a tactile screen in which he is receiving our orders, and he is doing the tasks. So we were able to map the cortex. ¿Se puede subir el volumen un poquito, por favor? ¿Se puede subir el volumen? Then we go deep and we look for the posterior part of the arcuate in case he has any troubles. So during the whole procedure, he's speaking with us, he's doing the tasks. And once we reach the deepest part, it's the place to try to find these optic radiations and to try to respect them. So this is the campimetry, intra-op campimetry. So we have 4 different movies, and the patient is always looking at this red cross in the center. Above here, you cannot see it, but we have a camera which is checking that this patient is not moving his eyes, because in case he moves his eyes, the campimetry is not valid. So while we are stimulating, he's gonna draw the deficit he's perceiving.
Punto número 1.
Perfecto.
So at some point we were stimulating this part here. This is the atrium.
Vamos a ello. Punto 2.
And he's drawing this kind of deficit, stimulating this part of the optic radiations.
Es como la derecha, pero es como si fuera, como si cambiara a negro.
He's explaining that it's like a shadow, like something dark.
No realmente grave. Grande, perdón.
But he said it's not very severe because he wanted us to continue removing tumor. Now in a different point,
Punto 3.
Sí, creo que un poco más arriba.
again he's drawing.
Por aquí. La la misma
Y
sombra.
siempre es como una sombra, ¿no?
Sí, exacto.
Es borroso, es luces, es oscuridad.
Sí, un poquito, que diría, sombra.
Vale.
It's a kind of shadow,
Que
he's saying.
deja de ser realmente como sharp. Sharp, sí, que no es definido. Lo ves como borroso. Exacto, es como una zona.
He was trained, and we were explaining him before surgery that once we have a deficit, we have identified this dysfunction, we should stop surgery. And in the calcar abyss, this is what he saw. So we could we could identify the arcuate aoptic gradations and to perform a good resection of this low-grade glioma. This is 3 months after surgery, so he had these small deficits, and he was doing the tasks in a very easy way. He's a bilingual guy, so we were checking in English and Spanish all these functions. And I want to highlight that all this work is not only a single guy work, it's a huge team which is working for that. These are my colleagues in my department. I thank them because I'm enjoying these days thanks to them, because they are taking good care of our patients. And I really thank you for your attention. And this is the conclusion. I want to highlight the white matter matters. Thank you so much.
Thank you, Pablo. Wonderful talk. Thank you very much. Questions? Questions, the public? I think one very interesting, important concept is the retinotopy in the sagittal striatum, right? Because you have a very beautiful retinotopy at the level of the lips of the Cacorine fissure, as you go from the occipital pole to the parieto-occipital sulcus. But you have some somatotopy, a very beautiful somatotopy in the optical radiations, which clearly demonstrated here with the case for the corrida man for the Myers loop, right? And for the other case, when you went from superiorly, and probably some parietal radiations were on the ray, and so you have a, yeah. Can you comment on that?
Well, yeah, I learned from that case that that was not a good way to go to the atrium, because the optic gradations are covering the whole thing, the whole atrium, and some thin ones are in the roof of the atrium, not only in the lateral wall. So this is why probably it happened. Thank you.
Yeah, I saw your stimulation of the optic pathway. I've only used monopolar and bipolar. Is there, from an electrophysiological perspective, is there a reason to use 3 poles?
There is a reason, and the neurophysiologist explained me for many, many times, but I cannot give you a perfect explanation about that. She told me that in order to stimulate the optic radiations, we need to try to, instead of stopping the signal, we have to try to stimulate it, to stimulate the optic radiations. But in fact, there was not a stimulation, it was inhibition, because the patient couldn't see. So I cannot give you but I will send you the explanation, scientific explanation from her. But that's the reason. She wanted to stimulate instead of inhibiting.
Right. There was a question there. It was just the,
Doctor, una pregunta. Es para abordajes hacia diferentes partes o lóbulos del cerebro que están, algunos proponen estos de abordajes parafasciculares con uso de sistemas tubulares, suponiendo que haya menos lesión y por lo tanto una mayor preservación de la función. ¿Cuál es su opinión con respecto a eso versus que sea como transurcales o transgirales como algunos de los videos que nos presentó?
No tengo experiencia con estos sistemas tubulares, pero en realidad es una buena idea. Cuando estamos haciendo, bien sea un abordaje transcortical o transulcal, en cada maniobra, cada movimiento, puede que estemos dañando fibras. Así que si la decisión es ir transcortical o transulcal, creo que es una buena opción. Creo que es mejor ir transulcal en ese caso, porque la distancia luego a la transgresión del córtex va a ser menor, y poner estos sistemas puede ser muy útil a la hora de evitar el daño cada vez que estamos entrando o espatuleando, pero también tienen un problema, y es que nos limitan muchísimo nuestros movimientos para tumores grandes o para lesiones que se expanden en diferentes ángulos de visión. Entiendo que va a haber que cambiar mucho la trayectoria de esos sistemas tubulares y al final vamos a dañar igualmente la corteza. No tengo experiencia, nunca lo he probado, pero me parece una buena opción.
cuando hacen abordaje transtentorial, ¿lo ponen en semisentado?
Para el transtentorial semisentado siempre, sí, siempre.
Si te has fijado, no sé, cuando uno opera transtentorial, ustedes resecan parte del tentorio, ¿cierto? Pero tenemos una limitante en la parte anterior hacia el uncus. No sé si ya te ha pasado operando.
Sí.
No llegas y el peñasco, es
Exacto.
decir, la punta del apex petroso es la que te limita, ¿no? Entonces uno quiere sacar todo, pero no podemos y dejamos la parte del uncus.
Exacto.
Es un tumor muy extenso, ¿no?
Para tratar...
Solo giro para hipocampal, tercio medio, tercio posterior, ¿no?
El tercio anterior es más complicado, por eso la fosa media, si estamos viendo desde abajo, tenemos el peñasco aquí arriba y la fosa media cae hacia abajo. Entonces, lo que hacemos habitualmente es hacer un estudio craniométrico y de ángulos de visión para ver cuánta sustancia nos puede quedar ahí abajo. Un truco muy bueno que me enseñó Touré es tratar de, una vez has llegado a la parte más anterior del peñasco, lo que hace es introducir pequeños algodoncitos debajo, por fuera del aracnoides, de forma que va elevando esa sustancia que queda ahí, la parte más basal, y la puede resecar. Es un buen truco. De todas formas, yo lo que he hecho en esos casos es utilizar un endoscopio de 30 grados y un CUSA y un espiral ultrasónico. De esa forma nos permite llegar un poquito a la parte más basal. Pero es una de las limitaciones de ese abordaje. Gracias, Richard.
Perdón, ¿hay alguna otra pregunta para el doctor?
Thank you, Pablo.
Bueno, creo que no. De todas maneras, le vamos a dar nuevamente un aplauso. Muchísimas gracias al doctor Pablo González López por la exposición de la mañana del día de hoy. A continuación vamos a tener ya la segunda exposición, que es fibras comisulares inter e intrahemisféricas, aplicaciones para la cirugía de epilepsia hemisférica y subhemisférica, con el doctor Roy Daniels. Vamos a pedir, por favor, que podamos apagar las luces para que podamos dar inicio a la siguiente conferencia de la mañana del día de hoy. Muchas gracias.
Good morning. I have to thank Professor Paragas, Professor Igor, and the organizers for giving us this opportunity to come here and visit your wonderful country and to participate in this great symposium. My topic today is on the disconnection epilepsy surgery. So inside the hemisphere and between the hemispheres. And you have all dissected in the lab yesterday the fibers that you want to keep, but then in epilepsy surgeries we want to destroy them. So it's a little different. It's always nice to know what you're cutting, and so it's very important to understand what you're cutting, and that's what we do in the lab. And for all neurosurgery we keep this intact, but for epilepsy surgery we cut all of them for a different reason, and I'll explain to you why. So if you look at how the brain develops, in the first decade you have maximum synaptic density, and therefore you have maximum cortical plasticity. So this is the period when we learn all the skills necessary for survival. And how does that happen? It happens by the branching of dendrites. It happens by synapses being formed and then myelination. So the majority of this activity takes place in the first decade. And then in the second decade, you start losing some of the synapses that you don't really need, and even some of the cells that you don't really need. So this is how the brain develops. So how do seizures impact brain development? And this is why seizures in children should be treated aggressively. So what do you need for development? You need some physiological stability. You need the electrical environment between the neurons to be stable. And most importantly, you need environmental stimuli, which means that we learn because we have experiences. And so this is very important. And what do seizures do? They produce transient anoxia, they have interictal discharges, they have postictal depression. Now all these phenomena adversely impact the brain development. And then these children have a lot of anti-epileptic drugs which can also impact brain development. But this is what is most important, because we are dealing with children who have hundreds of seizures per day. And if you have hundreds of seizures per day, they don't have too much time in which they can get sensory stimuli. Many of them don't go to school. Even talking to parents and family is interrupted by seizures. So sensory deprivation accounts to a lot of the cognitive problems that we see in children with intractable epilepsy. So all this thing will retard axonal growth and synaptogenesis. So this is why pediatric epilepsy surgery is something that needs to be treated aggressively. So if you look at epilepsy surgery techniques, the most simple is lesionectomy. You have a small lesion, you look at the tracts that you want to preserve and the cortices you want to preserve, and if you think you can remove the cortex without creating a neurological problem, you do what's called a lesionectomy. And then if it involves a whole lobe, the most common one is temporal lobe, you do a temporal lobectomy, making sure that you do not have a lobe or a fiber tract that will produce a new neurological deficit. But in the pediatric population, these epilepsy surgery techniques are more common. So these are large lesions of the hemisphere, the whole hemisphere, then you do a hemispherotomy, half of the hemisphere you do a quadrantotomy, and then you have multifocal epilepsy coming from both sides of the hemisphere, then you look for interhemispheric disconnection. There are other techniques like neuromodulation, vagal nerve stimulation, radiosurgery. So in this talk, I'm just looking at the disconnective techniques, so quadrantotomy, hemispherotomy, and interhemispheric disconnection. So who are the possible candidates for this kind of epilepsy? This is one condition that is very common. This is a rare disease, but in the population of people with hemispheric epilepsy, you have this particular syndrome in which these children have an intrauterine vascular insult which destroys one whole hemisphere, as you can see here. And so this is a very good candidate for a hemispheric epilepsy surgery. Then you have some congenital diseases like Sturge-Weber syndrome, which is a leptomeningeal angiomatosis. This is a progressive condition that involves, funnily, only one hemisphere. So you see this leptomeningeal angiomatosis, and this hemisphere slowly atrophies and does not have any function in that hemisphere. So another good indication. This is a very interesting syndrome, which is called hemimegalencephaly. Here the large hemisphere is the bad hemisphere. This hemisphere is dysfunctional and very epileptogenic. So this is the normal hemisphere. So all these diseases are atrophic hemispheric lesions. This is a hypertrophic hemispheric lesion. And this is probably the only acquired hemispheric disease, and this is an interesting syndrome described initially by Theodore Rasmussen in Montreal, in which you have a normal child, born normally and maybe up to 6 or 7 years has no major problems, and then starts getting focal epilepsy, focal motor epilepsy, which is rapidly progressive in the majority of cases, and they develop hemiplegia and get into status epilepticus. So this whole hemisphere progressively atrophies and loses its function. So this is quite an interesting condition and possibly the only acquired hemispheric disease. And these are all the more common ones, and they are all congenital. So what are the goals of hemispheric epilepsy surgery? Of course, we need to completely eliminate seizures. But what does eliminating seizures do? Because when seizures stop, then brain function starts developing in the normal hemisphere. And we should, of course, be absolutely sure that when we do the hemispherotomy, we are not creating a neurological deficit. But if you achieve all these objectives, then these children can assume near normal lives. So essentially, epilepsy, hemispheric epilepsy surgery, this is what it is. You have a bad hemisphere, you have a good hemisphere. This bad hemisphere does not really have any major function, and this hemisphere is not allowed to develop function if you have epilepsy coming from the bad hemisphere. So if you do a hemispherotomy here, this hemisphere eventually becomes a double hemisphere. All the functions that were supposed to be in this hemisphere develop in this. But that's why it's so important to do this when you have cortical plasticity still present. So a hemispheric epilepsy surgery in adulthood treats only the epilepsy, does not allow really brain development to happen. So hemispheric disconnection, it started with hemispherectomy actually, and it was first done for glioma by Dandy, but he still lost the patient because glioma is a brain disease and is not really a localized disease. The first series was from South Africa, but then the leaders really were the Canadians from the Montreal Neurological Institute, and Rasmussen, and then Vilmuir, who I worked with. They are the people who described what is called the hemispherotomy, and I'll show you what that means. So in hemispherotomy, there are 3 distinct stages, and you'll see in the lab what these stages amount to. So the first stage is the suprainsular window, and we described this quite in detail about 12 years back. And it is done through various windows because you want to keep these arteries intact. And once you go in, you will be doing a certain number of things. So you'll remove the frontoparietal operculum. That's part of the opercular removal. So very little brain removal, actually. And then you transect all the fibers that you're going to now see in the lab today. And once inside the ventricle, you do a parasagittal callosotomy. Then you cut the fornix at the posterior part, and then you disconnect the mesial and basal frontal lobe. So I'll try to show you some of these images. They're not as beautiful as the images that Pablo showed you before, but you will see many of these structures in the lab today. So you have to interrupt the frontoparietal U fibers as you go in, and then you come to the deeper white matter structures. Some of these slides are borrowed from Christophe Destru's lab, and eventually you will see the anterior and posterior limbs of the internal capsule, which are disconnected here to reach the ventricle. And then from inside the ventricle, so what are the functional correlates? You actually interrupt the anterior and posterior limbs of the internal capsule, the uncinate fasciculus arcade, fasciculus, and the IFOF on your way to the ventricle. So inside the ventricle, what you need to do is a complete callosotomy. And so all the discharges that arise from one hemisphere cannot go on to the other hemisphere. So it is actually a parasagittal callosotomy. So you start somewhere in the midline, and then you go anterior, and then you go posterior to complete the callosotomy. So inside the window, at the end of the splenial disconnection, you have access to the fornix. And so if you disconnect the fornix here, at least 70% of the temporal lobe output goes through the fornix, and at least epilepsy, a lot of it can be treated just by disconnecting the fornix. So that's what you call by a posterior hippocampotomy. Then there's one part of the frontal lobe that is a little difficult to conceptualize in images, and I always have problems showing it, and that's this part, which is the frontobasal disconnection. You're basically disconnecting the mesial and the basal part of the frontal lobe. So this needs to be disconnected because we really don't want to deal with the anterior commissure, and to avoid that, this lobe needs to be disconnected. Because the one thing you cannot have is a problem with the hemisphere on the other side. And so some of the procedures which endanger anything on the other side, sometimes we have to do an added disconnection. So this is what is called the frontobasal disconnection. And then you go on to the temporal side, and there you remove, like you saw before, the temporal opercular cortex. You cut the temporal stem, and then you cut the temporal stem to reach the ventricle. And there, in the process, you deal with the temporal U fibers, and then when on your way to the ventricle, what you're actually disconnecting, what Pablo showed you good images, the sub and retrolentiform parts of the internal capsule. So inside the ventricle, as I mentioned before, the amygdala and the head of the hippocampus has a lot of connections that we do not want to disconnect because of the fear of damaging the other hemisphere. They're very close to midline, perforating arteries, and therefore the manner to deal with that is to remove the amygdala and the head of the hippocampus. The rest of the hippocampus can be left in place because the fornix has been disconnected here previously. And the last stage of the operation is to disconnect the insula, because you can have insular seizures if you do not deal with the insula. So you could remove the insula, but a more elegant way of doing it is to disconnect it at the extreme and external capsule level. So that effectively disconnects the entire hemisphere. If you look at the EEG during the surgery, so this is before and this is after surgery, and the white traces show you the ipsilateral leads, and the yellow traces show the contralateral leads. So basically what happens is that whatever discharges you had which were transmitted from the bad hemisphere to the good hemisphere before the disconnection completely disappears, and you know that your disconnection is complete. But what's also interesting, you see, is that because the brain is not removed, it's only disconnected, you have increase in the electrical activity of the bad hemisphere. That's because there are a lot of inhibitory fibers in the corpus callosum, which when you lose that inhibition, and then the cortex becomes electrically more active. But we don't really care, because the epilepsy cannot spread anywhere. And if you do a graph of this, you can see at every stage how it changes. And there's a dramatic decrease just after the calosotomy. So you see the calosotomy here, and you see it completely stops propagating. So that shows the importance of calosotomy in epilepsy propagation in these kind of infants. So just one clinical example. This is a boy who came to us in '99. This was initially my first hemispheric epilepsy surgery. So the neurologist who treated him started with steroids, which is almost always the case, because he was normal till 8 years of life, and then started getting focal seizures. But it did not really help. He completely lost that hemisphere progressively. By 2000, there was a lot more atrophy, and he was having status. And this was almost continuous status. And whatever cognition he had before the development of this problem, he progressively started losing it. And there you see him he started going to school immediately. And then a few years later, he's a good Facebook friend with me, so I have images as recent as this year. He's done very well. He's finished his university. His language functions are excellent. And it shows the importance of doing it early in childhood, when you can have the possibility of developing normal function in a single hemisphere. So then we go on to the second topic, which is the subhemispheric epilepsy. So the hemisphere can be divided into two quadrants: the anterior quadrant, which is essentially the frontal lobe, and the posterior quadrant, which is the temporal, parietal, and occipital lobes. And these patients have residual motor function. So you cannot do a hemispherotomy. You need to keep motor function intact. Of course, this has to be a static condition. You cannot have a disease which is progressive, because then these kind of disconnective epilepsy surgeries are contraindicated. So what needs to be done is a disconnection of only the epileptogenic quadrant. Now this technique we published many years back, more than 10 years back, in which this whole posterior quadrant is disconnected. So you see the disconnection here. That's your post-op images which show the disconnection. I'll try to explain that. Again, you go through similar steps, so we can go faster. This is the infra-insular window. There's the temporal lobe resection part of it, only the mesial part. And then you have a step which is not there in hemispherotomy. You need to do an intraparietal disconnection. So the infra-insular window, again, it goes through removal of the temporal operculum. It is deepened to the circular cistern, inferior part of the circular cistern, and basically you're dealing with the intratemporal U fibers. Then you open the temporal horn and the atrium, and there you disconnect the sub and retrolentiform parts of the internal capsule. Hopefully you'll be able to see that in the lab today. And you deal with some parts of the end of the SLF and the arcuate fasciculus and the AFOF. The operculoparietal cortex is also incised at the level of the atrium. So the temporal lobe part is continued on to the atrium. And again, you open the ventricle along its way, only up to that. And inside the ventricle, because you don't want to deal with the anterior commissure, you remove the amygdala and the anterior hippocampus. So there you see that. And then you go to the intraparietal disconnection. So here you see you have a cortical incision posterior. So you need to find out where the postcentral sulcus is, and that is done with central sulcus mapping. And just behind the Rolandic cortex, you do a cortical incision to reach the ventricle again. Then you do disconnection of the posterior part of the callosum, and then disconnection of the fornix to interrupt the discharges that come from the hippocampus. So then we come to another technique that we recently published. It is the anterior quadrant disconnection. So it goes through similar steps. So it starts with an anterior suprainsular window, and there you deal with the inferior frontal gyrus, the frontal operculum, the circular sulc. So this is the circular cistern, and that gives you the guide. And there at that point you turn on to the ventricle to reach the frontal horn. And these are the structures you deal with. You deal with the uncinate fasciculus, the arcuate fasciculus, the EFOF. And then, of course, on your way to the ventricle, you'll be cutting the internal capsule, the anterior part of the internal capsule. Again, just like the posterior intraparietal disconnection, you'll do an intrafrontal disconnection. Again, you have to map the Rolandic cortex, and anterior to the precentral sulcus, you'll make an incision. On the medial side, you'll cut onto the cingulate gyrus, and the mesial part, you can see that the mesial part of the superior frontal gyrus. These are the structures you'll be cutting, the SLF and the intrafrontal fibers. And then inside the ventricle, you'll do a chalazotomy, only the anterior part of chalazotomy. And this is, the incision is given at the junction of the roof of the ventricle and the septum pellucidum. And this disconnection disconnects from the rostrum to the junction of the posterior and the mid-third of the body. And this we already covered. You again have to do the frontobasal disconnection like you do in a hemispherotomy. So we come to the last interhemispheric. So far we have done all intrahemispheric disconnection. This is the last part, and this is a technique that we have just sent for publication actually, which is a fully endoscopic intrahemispheric disconnection. It is indicated for multifocal epilepsy, but this, like the other techniques you saw, is not curative. It is only palliative, because both hemispheres are bad, and both hemispheres generate epilepsy. So you cannot do any kind of curative epilepsy surgeries, and you're dealt with. You need to deal with a palliative procedure. So this is a technique that Professor Sufyanov in Russia pioneered, and you see the position in which we operate these patients. They are completely flat. The head is turned completely almost 90 degrees, and it's an endoscopic entry, orthogonal, almost 90 degrees to the surface of the skull. And there you can plan your trajectories based on navigation. I got the lab in Tumen did some excellent white matter dissection and got some images from the lab. And this shows you the frontal projection of the third ventricle. So if you're inside the third ventricle and you're looking forwards to the front, you see the foramen of Monro on both sides. You see the anterior commissure here. You have the lamina terminalis, the optic apparatus in front of you, and the infundibulum here, and the infundibular recess. Now if you stand in the third ventricle and you look posteriorly, and with an endoscope, this is what you'll see. You'll see the habenular commissure here, you'll see the posterior commissure here, the aqueduct of Sylvius, the suprapineal recess, and the pineal recess. So these are the structures you'll see with your endoscope. And if you take a mid-sagittal section, you'll see the anterior commissure here, you'll see the posterior commissure, the habenular commissure. This is kind of an oblique view that shows you the optic apparatus here, the anterior commissure, you see the inside of the third ventricle, you see the pineal gland here, and the posterior commissure, just to give you an impression of the structures that we are going to deal with. So these dissections are all done in Sufyanov's lab in Tumen, Russia, and this shows you the excellent images, excellent dissections, which shows you the limbs of the internal capsule, and hopefully we'll be able to see this in the lab today, and the areas of the cortex that it deals with. And this is a split above the third ventricle, cut axially, and you can see the structures in the roof of the third ventricle here. And if you remove the roof, this is what you'll see. That's the interthalamic adhesion here, the posterior commissure and the habenular commissure and the pineal gland. So there's one short video if you have the time. Igor, do I have enough time for this? Okay. So this is a surgery that we have done, and Sufyanov, we have collaborated with him, and he has done, we have a series of now close to 30 patients. So, I'm sorry, I clicked on the wrong one. So you saw the trajectory to the ventricle. The first thing that you do inside the ventricle is to get into the third ventricle as early as possible, because this is the part of the surgery which is done with the flexible endoscope. And so it has got less resolution, and so you don't want the corpus callosum disconnection and the blood if it happens to destroy the visualization. So this, oh, come on. Excuse me. So that's the anterior commissure which is being disconnected there. And then with the flexible endoscope, you need to turn it around, and this is the tricky maneuver. It's never very easy to turn the flexible endoscope and get yourself oriented, because it's very easy to get lost in the third ventricular anatomy with the flexible endoscope. If it's a straight endoscope, your coordinates are very clear and you cannot see too much anyway. But with the flexible, you can see a lot of things. You can go in all kinds of difficult places. So the orientation is not easy, but there you get to see the suprapineal recess, and that is the posterior commissure and the aqueduct of Sylvius on one side. And the dissection can be done with bipolars or with forceps, and that's how you do it. You remove the posterior commissure, disconnect the posterior commissure, and then you go a little and then you go towards the habenular commissure. So it is done with a system by which you will have a little bit of bleeding, and the best way to deal with it is to have pressure water injection. So very heavy pressure injectors that are used by orthopedic surgeons for arthroscopy is used for this, and that allows you to keep your vision. And then you come out of the foramen Monro and you stay in the lateral ventricle, and this can be done with a straight regular endoscope which we use all the time. So the flexible endoscope is what the urologists use, and the pressure injector is what the orthopedicians use, essentially. This is standard neurosurgical equipment. And once inside the ventricle, you'll try to identify the junction of the septum pellucidum and the roof of the ventricle. And once you see it, this is a kind of monopolar or bipolar. One of them can be used, and you need to get to the fox on the other side. The minute you get into the fox, you know that the callosum in that part is completely disconnected, and you need to take the whole C of the callosum like that. So that's, you can see the posterior callosotomy, and that's the fox. You just glimpse the fox there, and you just have to keep visualizing the fox, and you go all around, and then you confirm it. You go and look in the pericallosal cistern for the pericallosal arteries to make sure that there are no fibers left behind. And I think we were able to show, yeah, that's a glimpse of the pericallosal arteries there. So this is essentially the procedure, now totally endoscopic, but it can only be done with infants with large ventricles, and so with small ventricles it would be very difficult. A combination of open and endoscopic will need to be done. So just to summarize the techniques that we discussed today, we started with hemispheric epilepsy surgery, in which one whole hemisphere was disconnected. Then we went on to a posterior quadrantotomy, in which the temporal, parietal, and occipital lobes were completely disconnected. Then we discussed the anterior quadrant, in which the frontal lobe was completely disconnected. And then we went on to a palliative procedure in which you have total interhemispheric disconnection, the anterior commissure, posterior commissure, and habenular commissure, and the corpus callosum. So I hope we can see some of this in the lab today. The human connectome is something that interests all of us. It is basically an entire map of estimated 600 trillion wires in the human brain. It's also important to realize that the connectome is in continuous flux. Our brains are not static. It keeps changing. The structure of our brains change every day with what we learn. At a cellular level, how is this studied? Most people look at microscopic level. They look for neuron synapses, genes, proteins, and brain chemistry, and based on which lab you work in, you kind of exaggerate what is more important than others. At a gross level, we do what we do in the lab for dissection to find out how the brain is connected, try to figure out as many of the 600 trillion wires as we can. Of course, histological techniques of staining can be done. But what's really important is what a lot of work that Pablo and Christoph are doing extensively in their labs is the evolution of diffuse tensor imaging, which is really changing the field, and hopefully we should be able to know more and more about the human connectome. There's a large US NIH funded human connectome project but we are decades, if not centuries away from completely figuring this out. European project, which is based in Lausanne, of all European partners of the Human Brain Project, looks at it from not little less anatomic and a little more computer modeling sequences, but integrating anatomic and basic science knowledge. Hopefully we should be able to figure out the normal physiology of the connectome and basically how do we think and how the brain works as it is, how the brain is affected in pathological states in psychiatric disease. Whether there is a specialty called psychiatry or not, or is it part of neuroscience, is another question altogether. And essentially who we are as mental beings, we hopefully will be able to figure it out. So the work that I showed you, the clinical work has been done in 3 hospitals, in India where I started, and now in Lausanne and in Russia. This is the lab that deals with all the connectivity of the amygdala in Lausanne. I've had a great time in this country. As you can see all around, we have tried to explore almost everything possible. I'm sure there's lots of it left. Pablo is really happy trying to mimic the tree here. And Vladimir Benich and the WFNS, thank you completely for giving us this great opportunity. Muchas gracias.
Vamos a pedir que nos prendan las luces, por favor. No sé si es que hay alguna pregunta para el doctor, para que pueda responder ahora.
Thank you, Zorai. It's splendid. You know, I was saying all this disconnection and wondering how it's, you know, it fits perfectly, you know, your lecture and what we're doing in the lab, you know. It's so nice to see that when with this white matter anatomy, you know what you're doing and you know what is cutting. Because if you show the same pictures of the same papers to many surgeons all around the world, many of them will say, "Oh, we just cut here, but you're not really, you're not have a really precise." Idea what exactly we're doing. So we're just discussing this morning. Sometimes we say, "Oh, let's do some white matter dissection." We do not figure out what all the implications are. One may think that we're just peeling some white matter. It may be fun, but it has a lot to do with intrinsic cerebral anatomy. It has a lot to do to dive and, you know, goes also a little bit science in the brain and orientating yourself and saying what is behind is just before is extremely important. It's like diving in the sea, or, you know, go into the CP angle, for example. And questions?
Thank you, Thomas. For the disconnections, do you have any experience that instead of doing that, maybe radiosurgery can provide the same effective result? Because we know that probably, I don't know, I don't have experience, maybe you can do stepwise doing the disconnections with radiosurgery. Thank you.
It's an interesting question, and people have explored it, but then you have to imagine that if you do radiosurgery, the number of targets that you have to do is massive. And the time to do that procedure itself will be so long, it'll be many days, I think, of radiosurgical treatment. And of course, then you have the problems with radionecrosis when you have different multiple targets. At the moment, the only indication for radiosurgery, 2 indications. One is reasonably proved. That is for hypothalamic hamartoma, because it's a small lesion. It's less than 3 centimeters. It's perfect. It's like a tumor, and you can hit it, and it's a difficult place to access surgically. So that is a great indication for radiosurgery. The other indication is where the group in Marseille has been propagating, and it has not yet been proved. They claim it is good, and that's for mesial temporal sclerosis. I'm a little worried about that. I would not do it for that. So hypothalamic hamartoma, a great indication. Disconnective surgery is almost impossible to do with radiosurgery because the number of targets are enormous.
Just something that was not very clear to me. For the hemispherotomy, you're doing your peninsular windows, right? And afterwards, you're going to the frontal-basal disconnection. How are you getting there? You're coming lateral, and then you know, because the picture you showed was, you know, frontal view, so I couldn't understand it.
Well, the approach is essentially lateral. And because of the microscope, you can go in and have a vision of the whole ventricle. But when you do the frontal-basal disconnection, one of those windows anteriorly in the frontal lobe is extended along the sphenoid ridge, and you cut onto the basal cortex. And then again, you work through that cavity to disconnect the mesial cortex, and then you reach the corpus callosum, the genu of the corpus callosum, which is previously disconnected. Yeah, it is through windows to keep. Initially, we were not doing windows, and then we had problems with 3 patients. Out of a series of close to 100, we had problems with 3 patients who developed brain swelling. Because the brain is there, and if you remove all the venous drainage, it can swell. And we had remote hemorrhages, which was the other complication related to that, of too much CSF drainage. So these are 2 complications. So essentially, if you try to minimize the opening and keep as many arteries and veins as possible, the complications can be almost completely avoided.
Definitely very seldom procedure. You need a whole lot of people, including neurologists, to do the workup and everything. I do not think that this is the procedure that should be done everywhere. You are from the department which has a long history. You yourself have a long history of epilepsy surgery. Tell me, how many centers do you think would be suitable for, say, country of 10 million or whole Europe? How many centers doing?
Not many. I would estimate 5 or 6 for the whole of Europe.
Si le pueden pasar el micrófono, por favor.
Yeah, I don't think more than 5 or 6 centers for hemispheric epilepsy. The number of cases are very small. We've been doing it for more than 20 years, and our entire series is, 120 now. And it's across different countries, India, Russia, Europe, Canada, all put together.
Silly question. Some of those cases, have you know, is the white matter the same? What are you feeling about, you know?
Yeah, it's not a silly question. The white matter is a lot more tough. Maybe it is compression of all the things, and all the fibers that are residual are all pushed together. And it is very tough, and very often we have to cut it with a bipolar. Never scissors, bipolar is faster, because if there's a little bleeding, it takes care of it. So it is tougher than the regular white matter that you see in glioma surgery. Thank you very much.
Sí, bueno, vamos a despedir con un fuerte aplauso, por favor, al doctor. A continuación vamos a recibir al doctor Richard Párraga con el tema Organización General de la Sustancia Blanca en el tronco cerebral y el cerebelo. Vamos a recibir, por favor, con un fuerte aplauso al doctor Párraga, quien a continuación nos va a proceder con lo que va a significar la exposición de la mañana de hoy. Vamos a, ¿quiere que ya apaguemos las luces, doctor, o todavía no? Que apaguemos las luces.
Por favor, gracias.
Sí, ya, muchas gracias.
Sorry, Igor, I speak in Spanish. Yes. Okay, thank you. El tema que tengo que dar ahora habla de la Organización General de la Sustancia Blanca del tronco cerebral. Es un tema un poco interesante y más enfocado hacia el punto de vista quirúrgico, que después los profesores de Indonesia van a ver los abordajes y todo eso, ¿cierto? Comenzando, definimos el tronco cerebral y sabemos que es una estructura del sistema nervioso central que se localiza entre la parte del diencéfalo en la parte superior y inferiormente la médula espinal. Si nosotros vemos, está constituido por 3 estructuras, uno que es el mesencéfalo, otro es la protuberancia y tenemos la parte del bulbo, ¿cierto? Si nosotros nos enfocamos en una estructura y vamos fragmentando toda esa información de cada uno de los segmentos, sabemos que el mesencéfalo va a tener una superficie anterior. Esta superficie anterior podemos identificarla y está cubierta por lo que nosotros conocemos por el uncus, ¿cierto? Y vemos de que el límite superior está dado por los tractos ópticos y el límite inferior está dado por el surco ponto mesencefálico. Vemos que en esta superficie anterior tenemos las bases del pedúnculo cerebral que se van a diverger o van a separarse en sentido superior y van a formar este espacio que se llama el espacio perforado posterior, que tiene una base localizada hacia los cuerpos mamilares y un vértice localizado en el punto ciego superior, ¿cierto? Si nosotros nos fijamos, vemos claramente cómo está cubierta está cubierto este segmento por esta estructura. Aquí vemos el giro ambiens del uncus y vemos en la parte del uncus. Recordemos, es importante desde el punto de vista anatómico recordar de que del giro ambiens del uncus marcamos una línea imaginaria y para adelante tenemos la amígdala, para atrás tenemos la cabeza del hipocampo. Eso lógicamente cuando nosotros planeamos tratamientos de lesiones que se encuentran localizadas por delante de este segmento, especialmente cavernomas, ¿no? Y la parte posterior cuando nosotros hacemos resecciones en amígdalo hipocampectomía. Si nosotros nos fijamos también, vemos de que tenemos la localización del tercer par craneano. Vamos a ver de que la cara lateral del mesencéfalo, ¿no? Podemos dividir por esta estructura que se llama surco mesencefálico lateral. Este surco mesencefálico lateral se prolonga desde el surco interpeduncular que está a nivel de la protuberancia, ¿no? Sube para arriba y va a terminar a nivel del cuerpo geniculado medial. Vemos de que esta superficie lateral va a dividir la parte del mesencéfalo en una porción anterior que se continúa con la base del pedúnculo cerebral y una parte posterior que en realidad nosotros denominamos de trígono acústico. ¿Por qué? Si está limitado lateralmente por el pedúnculo cerebral superior, anteriormente por el surco mesencefálico lateral y superiormente está dividido por el brazo conjuntival inferior, ¿cierto? Sabemos de que desde el punto de vista topográfico, toda la parte del fascículo o lemnisco lateral que está en relación con la audición va a estar relacionado en este segmento. Es por eso que se llama trígono lemniscal o trígono acústico. Si nosotros hacemos una magnificación en este segmento, es el surco mesencefálico lateral, muy importante desde el punto de vista quirúrgico porque nosotros utilizamos este segmento cuando nosotros abordamos al tronco cerebral, ¿no? Recordemos que está en la parte anterior, la base del pedúnculo cerebral, y la parte posterior, vemos acá el lemnisco lateral, es el trígono lemniscal o trígono acústico. Vemos la emergencia en este segmento del cuarto par craneano. Desde el punto de vista de arquitectura intrínseca del cerebro, este es un gráfico que es muy importante recordar. Recordemos de que tenemos el acueducto cerebral, es un corte axial, y sabemos que si marcamos una línea imaginaria en este segmento, vamos a ver de que la parte anterior es el pedúnculo cerebral y la parte posterior es la parte del tectum, ¿cierto? Esta parte anterior, que es el pedúnculo cerebral, a la vez se divide en dos segmentos, ¿no? Uno que es la cruz del cerebro, es decir, la cruz o base del pedúnculo, y en una porción posterior que es cuadrangular, que está constituida por el tegmento. Entonces es importante ver esta disposición porque cuando nosotros disecamos, como estamos hablando, la parte de sustancia blanca del cerebro o del tronco cerebral, nosotros tenemos que saber de que las estructuras, tanto los fascículos que ascienden o descienden, es un poco complicado disecarlos. Hemos tenido varios artículos que hemos revisado con el equipo del doctor Evandro de Oliveira, aquí está Rafael también, ¿no? En donde hay artículos que nos muestran múltiples fascículos disecados por técnica de Klingler, pero no sé si Pablo ya después nos va a orientar un poquito más. Es muy complicado. Yo considero, en este trabajo nosotros hemos enfocado de que la mayor parte de las fibras disecadas por técnica de Klingler son las de mayor calibre. ¿Qué quiere decir? La vía piramidal, la vía del lemnisco medial, que es la vía sensitiva, y también la vía acústica. Pero para tener en cuenta, ¿no? En la base del pedúnculo cerebral tenemos la vía motora, ¿cierto? Y vamos a identificar que esta vía motora va a estar dividida en tres partes: un tercio interno, un tercio medio y posterior. En este tercio interno están yendo todas las fibras que van a venir del frontopontinas, ¿cierto? En la parte, y también la corticonuclear. En la parte media es la que está bajando toda la vía piramidal, es decir, corticoespinal, y en la parte lateral es la más noble, podríamos decirlo así, porque está bajando todas las fibras parietotemporopontinas, occipitopontinas, o las de Arnold y Turk en la parte posterior, y esas lógicamente en un momento determinado nosotros las podemos lesionar cuando nosotros hacemos cirugía sin tener lesiones importantes desde el punto de vista funcional. Lógicamente cuando hablamos de cirugía de tronco cerebral es importante que se haga la monitorización transoperatoria. Ya en el tegmento del mesencéfalo nosotros tenemos que dividir lógicamente la sustancia blanca y la sustancia gris. Esta sustancia gris nosotros dividimos en aquellas sustancias gris que son propias del mesencéfalo, como tenemos acá el núcleo rojo, y aquella sustancia gris que es homóloga a la médula. Vamos a ver en esta diapositiva, ¿no? Donde nosotros hacemos un diseño y un gráfico y vemos que a nivel de la médula y en la parte inferior del bulbo hay decusaciones. ¿Qué quiere decir? Se cruzan las fibras, tanto de la vía motora como también de la vía sensitiva, y hace de que los fascículos, o es decir, la sustancia gris se vaya fragmentando. Entonces esa fragmentación de la sustancia gris va a hacer de que forme los núcleos de los pares craneales, lógicamente que van a ser homólogas a la parte de la médula espinal. Ya vamos a ir hablando más adelante, pero vemos como la parte del asta anterior de la sustancia gris de la médula, lógicamente tiene una parte que es la base y otra parte que es la cabeza, al igual que la sustancia gris posterior que está en relación a la parte sensitiva. Desde el punto de vista motor sabemos de que a nivel del mesencéfalo lo único que vamos a tener son el núcleo motor es decir, el núcleo del tercer par craneano y el núcleo troclear, es decir, del cuarto par craneano. Si nosotros nos fijamos, es una vista anterolateral disecado con técnica de Klingler, vemos acá la parte de la corona radiada, ¿cierto? Tenemos el fascículo longitudinal superior, tenemos la corona radiada, hemos cortado, se va a hacer el corte ahora en la tarde para poder identificar toda la parte de la vía córtico-espinal, es decir, las fibras de proyección, y vemos acá claramente cómo está, tenemos la corona radiada, tenemos el límite de inserción donde estaba localizado el putamen, ¿cierto? Hemos retirado el globo pálido y vean cómo nosotros podemos localizar todas las fibras que forman parte de la cápsula interna. Este es el brazo anterior, la rodilla y la parte del brazo posterior. Lógicamente, si nosotros quitamos todo ese segmento, vamos a identificar la porción retro y la porción sublenticular. Vean cómo toda la cápsula interna se compacta. Se va a compactar y por debajo de lo que es el tracto óptico va a formar la base del pedúnculo cerebral. Entonces recordemos de que este segmento de acá, un tercio interno, está formado ¿por qué? Por las fibras frontopontinas o el fascículo de Arnold. La parte media es el tercio medio, que es el más importante porque está bajando toda la vía corticoespinal, y la parte posterior, que es la vía temporo, occipito y parietopontina. Cuando nosotros enfocamos el tratamiento quirúrgico en estos segmentos, lógicamente nosotros vemos, por ejemplo, cavernomas o tumores, siempre desde el punto de vista técnica quirúrgica, nosotros vamos a abordar en el punto donde el tumor o la lesión, el cavernoma o el angioma cavernoso se va a exponer en la porción superficial del tronco cerebral. Pero si no tenemos puntos de abordaje, es decir, exposición, nosotros podemos abordar en la porción anterior del mesencéfalo, ¿cierto? Un abordaje puede ser terrenal, pretemporal, y nosotros lateral al tercer par craneano ingresemos a la porción del tercio interno de la base del pedúnculo cerebral, y lógicamente el surco mesencefálico lateral, como vamos a ir mostrando posteriormente. Ya hablando de la sustancia gris, vamos a ver de que la sustancia gris, como les había indicado, nosotros tenemos que dividir una sustancia gris que va a ser homóloga a la médula espinal, ¿cierto? En este caso vamos a ver de qué tenemos, para que se puedan ubicar. Aquí tenemos el bloque central del cerebro, aquí hemos dejado la parte de la ínsula, es el tálamo, es la parte de la crura del fornix, vemos el cuerpo del hipocampo, tenemos la cabeza del hipocampo, aquí tenemos el pulvinar del tálamo, el cuerpo geniculado medial, ¿cierto? Tenemos la glándula pineal con su comisura posterior. el colículo superior, colículo inferior, hemos hecho un corte a este nivel, hemos quitado tanto el colículo superior e inferior solamente para exponer la parte del acueducto cerebral y lógicamente quitando toda la parte de la membrana que cubre el epéndimo o la membrana ependimaria, identificamos la sustancia gris periacueductal. Sabemos desde el punto de vista topográfico que la sustancia gris periacueductal en la porción a nivel del colículo inferior, sabemos que está localizado el núcleo del cuarto par craneano, ¿no? Y en la parte del colículo superior tenemos el núcleo que origina el tercer par craneano. Solamente para identificar otras estructuras tenemos acá el pedúnculo cerebral superior. Esta estructura, pedúnculo cerebral superior, pedúnculo cerebral medio, tenemos el quinto par craneano. Recordemos que de acá para medial es la protuberancia y de acá para lateral es pedúnculo cerebral medio. Este surco interpeduncular es importante porque sabemos de que este es el surco mesencefálico lateral, lesiones que se van a localizar en la porción lateral del mesencéfalo o van a localizarse también en el tegmento de la protuberancia, nosotros podemos ingresar en este surco si no tenemos un punto de exposición de la lesión, ¿cierto? Nosotros eliminamos, vean en esta fotografía, en este otro segmento, de que el cerebelo, el hemisferio cerebral tapa esa estructura, el lóbulo cuadrangular. Entonces, en ocasiones, nosotros, siempre, paciente en semisentado, resecamos la parte del lóbulo cuadrangular infratentorial y podemos acceder a este segmento que es el surco mesencefálico lateral. En ocasiones, no hay necesidad, solamente abrimos un poco del tentorio, ¿no? Pero para lesiones que se encuentran tanto en la base de la protuberancia, en el tegmento de la protuberancia y en pedúnculo cerebral superior, es necesario siempre quitar la parte del lóbulo cuadrangular del cerebelo. Es otra pieza anatómica que hemos hecho, hemos quitado parte de lo que es el colículo superior, el colículo inferior, y vemos aquí el acueducto de Silvio. Recordemos que el acueducto, este acueducto cerebral comunica el tercer ventrículo que está en este segmento y va a comunicar el cuarto ventrículo, ¿cierto? Vamos a ver de que la sustancia gris periacueductal da origen a nivel de lo que es el colículo inferior, tenemos el núcleo de origen del cuarto par craneano. Vemos que el cuarto par craneano es el único par craneano que va a salir de la superficie posterior del tronco cerebral, y vean aquí el frenillo del velo medular superior, lógicamente salen lateral a ellos, ¿cierto? Vean solamente para que se pueda ubicar, tenemos aquí el pedúnculo cerebral superior, tenemos el lemnisco lateral que está en relación a la audición, el lemnisco medio que es la parte sensitiva, aquí tenemos el núcleo rojo, para que se pueda ubicar un poco en la disección. Esta es una superficie medial del cerebelo donde hemos hecho una disección de toda la sustancia blanca, solamente para que se puedan localizar. Tenemos aquí el cuerpo calloso. El cuerpo calloso, recuerden que tiene una parte que es el rostrum, tenemos la rodilla, tenemos el cuerpo, tenemos el esplenio, vean el tapete, ¿no? Y vamos a enfocarnos en esta región. ¿Para qué? Para poder identificar la sustancia tanto homóloga como es el núcleo del tercer par craneano. Recuerden que está a nivel o a la altura de lo que es el colículo superior, ¿cierto? Vean cómo nosotros estamos identificando acá en la sustancia gris periacueductal, tenemos el núcleo del tercer par craneano y vemos la emergencia del tercer par craneano a nivel del surco dentro de lo que es la cisterna interpeduncular. Si podemos identificar en esta diapositiva, también vemos otra sustancia que va a ser propia del mesencéfalo que se llama núcleo rojo. Este núcleo rojo está dividido en dos segmentos, un tercio superior, subtalámico, y una porción mesencefálica. Por este fascículo que se llama fascículo retroreflexo de Meiner, ¿no? Que está uniendo los núcleos interpedunculares y está yendo hacia la comisura de la vénula, ¿no? Y podemos identificar también este segmento que es el núcleo subtalámico. Solo para tener una idea, tenemos acá toda la dirección del fornix. Recuerden que esta es la crura del fornix, tenemos el cuerpo del fornix, la columna anterior del fornix, cuerpo mamilar, el fascículo de Bigdasir, que es el mamilo talámico, hacia el núcleo anterior del tálamo, ¿cierto? Del tálamo, ¿cierto? Aquí vemos la comisura anterior, ¿no? Si nosotros vamos fragmentando, quitamos toda la parte de la motora, es decir, la base del pedúnculo cerebral, nosotros podemos identificar, fíjense, aquí tenemos surco mesencefálico lateral, vemos el tálamo en la parte superior, tenemos la emergencia del tercer par craneano, tenemos un fragmento de la base del pedúnculo, resecamos y encontramos otra sustancia gris propia del mesencéfalo, que es la sustancia negra, ¿cierto? Al remover la sustancia negra ya identificamos, vamos a hacer un close-up en esta región, identificamos este núcleo, que es el núcleo rojo. Estamos viendo en la superficie anterolateral del mesencéfalo, ¿cierto? Identificamos esta estructura, que es el núcleo blanco de Stilling, que no es más que la decusación de esta estructura que se llama pedúnculo cerebral superior, que lógicamente llegando a la parte del tálamo va a dividirse en la vía rubro talámica, ¿cierto? Vamos a ver de qué tenemos acá el lemnisco medial, este lemnisco medial que es parte de la vía de la sensibilidad profunda consciente y va a terminar a nivel del núcleo ventral posterolateral del tálamo. Vean cómo se ve aquí el tálamo. Recuerden que el tálamo tiene una prolongación lateral que forma parte del metatálamo. Aquí tenemos el cuerpo geniculado lateral, que ya se había visto en las disecciones de Pablo, que es la parte de la radiación óptica, ¿no? Y tenemos acá el cuerpo geniculado medial. El lateral, recuerden que está en relación con la visión, y el medial, que está en relación con la audición, ¿no? Entonces vean todo lo que es la vía sensitiva, la vía motora, que lógicamente ya la hemos fragmentado, ¿no? Entonces vamos a ver otras vías ascendentes importantes de fibra de sustancia blanca del mesencéfalo. Es esta estructura, ¿cierto? Tenemos el lemnisco lateral. El lemnisco lateral es la vía acústica central. Recuerden que se va a formar a nivel de la protuberancia después de formar el cuerpo trapezoide. Suben por encima de lo que es el quinto par craneano, se localizan en el trígono lemniscal, un trígono acústico, terminan en el cuerpo, en el colículo inferior, y a través de lo que es el brazo conjuntival inferior, termina a nivel del cuerpo mamilar, es decir, del cuerpo geniculado medial, y de ahí a través de las radiaciones acústicas van a terminar en el giro transverso de Heschel, ¿cierto? Vean acá tenemos el pedúnculo cerebral superior, y vean el lemnisco medial, que es la vía sensitiva más importante que tenemos, que está yendo a terminar en el tálamo, y aquí tenemos la sustancia negra, ¿no? Otra vía ascendente que también va a formar parte del mesencéfalo es esta estructura, que es el pedúnculo cerebral superior, que lógicamente al meterse a nivel del mesencéfalo se localiza por delante de los núcleos de los pares craneales a nivel del mesencéfalo, y se va a decusar, es decir, se junta con el otro, forma la decusación de Wernicke. ¿Y de dónde se está originando? Se está originando del núcleo dentado. Es importante, y siempre les digo cuando nosotros operamos en fosa posterior, de que esta estructura, que es tal vez la más importante que nosotros tenemos en el cerebelo, porque después el resto lo podemos quitar. Hace poquito hemos operado un tumor donde hemos quitado casi la mayor parte del mesencéfalo, y el paciente ha salido íntegro, sin ninguna lesión, sin ningún síntoma cerebeloso. ¿Qué cuidado hemos tenido? Debemos recordar que tenemos acá la parte de la parte del vermis, unos 2 centímetros laterales al vermis. Sabemos que está el núcleo dentado en la parte medial, entonces nosotros siempre tenemos que localizarnos, o podemos resecar la parte más lateral. El cerebelo es de las estructuras más nobles, independientemente nosotros las resequemos, seamos agresivos en resección, ya sea de malformaciones arteriovenosas, tumores, el paciente puede tener una evolución más adecuada, ¿cierto? Si nosotros lesionamos esta estructura, que es el núcleo dentado del cerebelo, generalmente pueden tener lógicamente intensificado la parte de dismetría, disdidad o cocinesia, pero pueden salir también con mutismo cerebelar, ¿no? Si nosotros nos fijamos en otro espécimen anatómico, vemos cómo está subiendo la parte del pedúnculo cerebral superior. Tenemos que resecar o cortar la parte del lemnisco lateral, que es auditivo, el lemnisco medial, que es la sensibilidad, y vemos que se localizan o se cruzan por debajo del núcleo rojo y forman la parte del núcleo de la decusación del pedúnculo cerebral superior, que es la decusación de Wernicke, ¿cierto? Entonces de acá luego se van al tálamo y luego a la parte de la corteza. Si nosotros hablamos ahora de la protuberancia, es importante entender de que la protuberancia tiene una superficie anterior y una superficie lateral y posterior. Si nosotros vemos desde el punto de vista ya descriptivo en la superficie anterior, sabemos que está limitada en la parte superior por el surco pontomesencefálico, en la parte inferior por el surco pontobulbar. Sabemos que tiene una forma redondada en sentido transversal y que tiene en la parte media de la protuberancia este surco que se llama surco de la impresión del tronco de la basilar, y tenemos los rodetes bulbares lateralmente. Tenemos la emergencia de lo que es el quinto par craneano y sabemos de que medial a esta es la protuberancia, lateral al quinto par craneano tenemos el pedúnculo cerebelar medio. Vemos cómo tenemos el ángulo pontocerebeloso en este segmento y lógicamente las fisuras cerebelo-pontinas, ¿cierto? Entonces sabemos entonces de que tiene una forma cuadrangular. En la parte lateral es otro espécimen anatómico. Sabemos de que está constituido generalmente por lo que es el pedúnculo cerebelar medio. Vean la emergencia del quinto par craneano, lógicamente con la parte más gruesa, que es la parte motora, sensitiva, y la parte motora, la parte más medial, y sabemos de que tenemos este surco que les había mencionado anteriormente, surco interpeduncular, pedúnculo cerebelar superior, pedúnculo cerebelar medio. Aquí teníamos el lóbulo cuadrangular del cerebelo en la superficie tentorial del cerebelo. Entonces nosotros tenemos que resecar el lóbulo cuadrangular para que tengamos un acceso importante a este segmento, ¿cierto? Al surco interpeduncular. Es una vía y es un punto de acceso hacia estructuras, ya sea del pedúnculo cerebral medio, del pedúnculo cerebral superior o del tegmento de la protuberancia, cuando no tenemos, digamos, exposición de la lesión hacia su superficie. Aquí tenemos la parte del borde libre de la tienda, tenemos el cuarto par craneano. Vean esta referencia del borde libre de la tienda. Aquí tenemos el surco mesencefálico lateral, ¿cierto? En ocasiones, cuando nosotros hacemos un abordaje supracerebelar infratentorial, no podemos acceder de manera adecuada al surco mesencefálico lateral, entonces nosotros tenemos que cortar lógicamente más posterior, preservando el cuarto par craneano, cortamos y podemos acceder de manera más importante. Vean la celación, esto es importante, surco mesencefálico lateral. Yo sé que en la parte anterior del surco mesencefálico lateral para adelante tenemos la base del pedúnculo cerebral, pero vemos cómo está la sustancia negra, posterior a la base del pedúnculo, y en la parte posterior tenemos que toda la parte del tegmento. Vean el núcleo rojo, lógicamente este se encarga del tono muscular, aunque cuando tenemos lesiones, cavernomas, gliomas dentro del tronco cerebral, lógicamente se deforma la anatomía, pero es necesario que se pueda entender de que hay posibilidades de acceder a esta región. En la protuberancia también es importante entender de que también la parte motora siempre se localiza en la porción anterior. Tenemos el cuerpo trapezoide que va a dividir en una base de la protuberancia y una porción posterior donde se va a denominar el tegmento de la protuberancia. Vean de que después de la parte de la base siempre tenemos la vía sensitiva. Tenemos el lemnisco medial, que es la vía de la sensibilidad profunda consciente, el tracto espinotalámico, y tenemos el lemnisco lateral. Ya recuerden de que después de que se forma del cuerpo trapezoide y del quinto par craneano sube, siempre se va a localizar en la parte más lateral. Tenemos también los núcleos pares craneales que se van a hacer homólogas a la parte de la médula, ¿cierto? Y aquellos pares craneales que van a ser propios de la protuberancia, que vamos a ver posteriormente. Importante saber de que a nivel de lo que es la base de la protuberancia, sabemos que hay fascículos que lo van a cruzar, van a fragmentar. Estos fascículos transversos van a ser las fibras pontocerebelares. ¿Qué quiere decir? Del córtex cerebral llegan hasta la protuberancia, formando la vía pontocerebela o cerebelopontina, y van a fragmentar la vía piramidal, como lo vamos a ver en la disección, ¿cierto? Si nosotros vemos esta imagen, es una vista panorámica de la superficie anterior del tronco cerebral. Lógicamente tenemos el encéfalo en esta región. Vemos cómo la base del pedúnculo cerebral siempre es compacta, ¿no? Aquí tenemos el mesocéfalo, tenemos la cisterna interpeduncular, los cuerpos mamilares. Hemos cortado, hemos hecho una ventana y hemos resecado todas las fibras transversas que van a conformar la vía ponto cerebelar, que forman parte de lo que es el pedúnculo cerebelar medio, y vean cómo se fragmenta la vía piramidal. ¿Por qué? Por las fibras ponto cerebelares. Si nosotros hacemos un close-up en esa región, vamos a ver de que vemos todas estas fascículos que van a estar fragmentados, ¿cierto? Estas fibras pontocerebelares van a conformar el pedúnculo cerebral medio. Vean cómo tenemos acá el quinto par craneano, vamos a ver en otra disección, en esta principalmente, donde la vía piramidal, es decir, la vía córtico-espinal, siempre se localiza más medial, y entre el quinto par craneano y la parte de la vía piramidal, que es la córtico-espinal, hay un espacio que se llama espacio peritrigeminal, que está descrito en algunos artículos también del doctor Evandro, ¿no? Y nosotros lo hemos publicado como unos puntos de acceso cuando tenemos lesiones localizadas a nivel de la base, a nivel del tegmento de la protuberancia. Es un espacio que nosotros tenemos que tomar en cuenta cuando tenemos lesiones que no se exponen a la superficie del tronco cerebral, ¿cierto? Quinto par craneano, pedúnculo cerebeloso medio. Recordemos que en profundidad de este espacio tenemos que recordar que tenemos la vía sensitiva principal, que es el lemnisco medial. Si nosotros cambiamos de posiciones ese mismo espécimen anatómico, vemos la base del pedúnculo cerebral, vemos toda la vía córtico-espinal que está fragmentada, y vemos también la vía pontocerebelosa, y por detrás del cuerpo trapezoide identificamos esta estructura, que es el lemnisco medial, que es la vía sensitiva más importante. Hemos hecho un corte acá porque para poder identificar el núcleo blanco de Stilling, que no es más que la decusación del pedúnculo cerebelar superior, ¿cierto? Y recordemos que este lemnisco medial se va a originar en la parte del bulbo, ya lo vamos a mencionar, y siempre se localiza medialmente a la parte del quinto par craneano. Vean cómo el quinto par craneano se encuentra siempre, la raíz más gruesa es la parte sensitiva y la raíz más delgada es la raíz motora. Ya enfocándonos en el bulbo, vamos a ver de que el bulbo tiene una superficie anterior, una superficie anterolateral y una superficie posterior. En la superficie anterior vamos a ver de que está limitado superiormente por el surco ponto vulvar, inferiormente por la decusación de la vía piramidal, ¿cierto? O la emergencia de la primer ramo cervical, y vamos a identificar estructuras. Tenemos un surco mediano anterior, y lateral a él ya tenemos los rodetes piramidales, que no es más que el trayecto de la vía córtico-espinal. Tenemos un surco anterolateral, un surco posterolateral, como identificamos en esta otra diapositiva, y que este surco anterolateral y posterolateral va a dividir la superficie lateral del bulbo raquídeo en una porción que va a estar ocupada por la oliva superior, ¿cierto? La oliva inferior. Esta oliva inferior, recuerden de que no llega hasta el surco ponto vulvar, entonces forma una foseta supraolivar. Posteriormente tampoco llega hasta el surco ponto vulvar lateral, y eso hace de que veamos este surco forma otro espacio que se llama foseta lateral del bulbo. Vean de que el sexto par craneano se está originando a nivel, la parte más superior del surco punto vulvar, pero a nivel de la pirámide vulvar, ¿cierto? En la parte anterior o anterior, en el surco anterior del oliva, tenemos la emergencia del 12º par craneano. En el surco posterolateral vamos a tener la emergencia de los pares craneales bajos, vemos aquí el 9º, el 10º, el 11º, ¿cierto? Si nosotros empezamos a ver, esta es una de las estructuras más complejas que tenemos tal vez dentro del tronco cerebral, que es el piso del cuarto ventrículo. Tal vez dentro del punto de vista de esta clase tal vez no la vayamos a desarrollar de manera más importante, pero vamos a ver de que tiene una forma romboide, ¿cierto? Que tiene un vértice superior, un vértice inferior, y vemos de que la pared tres partes, una parte superior, ¿cierto? Una parte intermedia y una parte inferior. Si nosotros nos fijamos, tiene un surco en el medio. Recordemos que en la parte superior el pedúnculo cerebelar superior va a limitar lateralmente el piso del cuarto ventrículo. En la parte inferior lo está limitando la parte del pedúnculo cerebral inferior, ¿cierto? Y en la parte intermedia vamos a ver de que no es más que líneas imaginarias que vamos a marcar a nivel de lo que es la parte del pedúnculo cerebral inferior. Cuando se voltea pasa por delante del receso lateral y regresa hacia el cerebelo, y tenemos la inserción de lo que es el receso lateral, ¿cierto? Rápidamente vamos a ver de que este surco medio, tenemos un surco limitante. Recordemos que del surco limitante lateralmente vamos a tener las estructuras sensitivas, y medialmente vamos a tener las estructuras motoras. Esta estructura, este abombamiento que vemos a nivel del piso en la porción de la protuberancia, se llama colículo facial. ¿Por qué? Porque es la representación del núcleo del sexto par craneano y la rodilla del nervio facial. Importante desde el punto de vista quirúrgico, sí, porque sabemos que nosotros no podemos acceder en esta región, porque sabemos que vamos a lesionar y el paciente va a salir con parálisis facial bilateral, ¿cierto? En la parte más importante y más delicada que tenemos en el piso del ventrículo, del cuarto ventrículo, es esta estructura que se llama el triángulo inferior o bulbar, que la conocían como cálamos scriptorio, ¿cierto? Este cálamo scriptorio está dividido en 3 segmentos: una parte interna, una parte media y una parte externa. Esta parte interna o es ala blanca interna, que está en relación a la representación del núcleo del hipogloso. El ala blanca externa está en relación al núcleo vestíbulo coclear, y el ala blanca o ala gris, que está es la parte del núcleo dorsal del vago, ¿cierto? Si nosotros vamos fragmentando nuevamente la arquitectura intrínseca del tronco del bulbo, sabemos que la parte motora siempre se localiza en la parte anterior, pero recuerden que la protuberancia está fragmentada y a nivel del bulbo nuevamente se compacta formando la pirámide bulbar. Recuerden siempre que la parte sensitiva se localiza posterior. Vean el menisco medial, que es la sensibilidad profunda consciente, el tracto tectoespinal y el fascículo longitudinal medial. No había mencionado esto, pero este fascículo longitudinal medial siempre se localiza a nivel del tegmento del tronco cerebral, siempre en la parte más posterior, y es el fascículo de asociación más importante que tenemos en relación en nivel del tronco, que coordina los movimientos conjugados de los ojos con la parte de la cabeza y el cuello, ¿cierto? Y al igual que en todas las estructuras del mesencéfalo, protuberancia y bulbo, tenemos una sustancia gris que va a ser propia del bulbo, como tenemos la oliva inferior, ¿no? Y aquellos pares o núcleos que van a ser de sustancia homóloga o parecida a la de la médula, como tenemos acá el núcleo del hipogloso. Como mencionábamos acá, vean la vía córtico-espinal, vean este segmento que ya, vean cómo baja la parte fragmentada a nivel de la protuberancia y nuevamente se compacta a nivel del bulbo, forma la pirámide bulbar y termina en la decusación de la vía piramidal. Eso corta la sustancia gris, y es por eso que se empiezan a fragmentar la sustancia gris formando los núcleos de los pares craneales. Hacemos otra pieza anatómica, y si nosotros nos hacemos un close-up en esta región, vemos que hemos quitado la base del pedúnculo cerebral, es decir, la pirámide bulbar. Identificamos una estructura de sustancia blanca en profundidad, que era el lemnisco medial. Recuerden que este lemnisco medial se está originando, son fibras que se originan o se van a compactar acá, pero se están originando en los núcleos de Gore y de Burdach, es decir, el grácil cuneiforme en la parte posterior, y estos núcleos van a dar fibras arqueadas internas que van a fragmentar también la sustancia gris y se van a localizar posteriores a la pirámide bulbar. Vean claramente cómo la vía piramidal en este segmento se está decusando. ¿Qué quiere decir? Está cruzándose al lado contralateral, y eso hace de que fragmente también la sustancia gris y principalmente delimite el tronco cerebral para arriba y en la parte de la médula para abajo. Esto es una imagen esquemática de lo que nosotros habíamos publicado. Lo que yo explicaba al inicio era de que estas estructuras son las que nosotros podemos disecar en disección de fibra blanca. El resto de las fibras tectoespinales y en infinidad de fascículos que tenemos en el tronco cerebral es muy complicado disecar por sus dimensiones, ¿cierto? A pesar de que nosotros hemos disecado con microscopio. Entonces, ¿qué vemos? El tálamo acá, la vía motora siempre en la parte anterior, ¿cierto? Y la vía sensitiva siempre en la parte posterior. Lo mismo, la misma pieza anatómica, tálamo, recuerda el lemnisco medial, termina a nivel del tálamo, el núcleo rojo, ¿cierto? La decursación del pedúnculo cerebral superior, que forma la decursación de Wernicke o núcleo blanco de Stilling, ¿no? Y vemos la sustancia blanca o la vía corticoespinal, cómo se fragmenta a nivel de la protuberancia y nuevamente cómo se compacta. Sabemos que en profundidad, en este espacio entre la vía corticoespinal y el quinto par craneano, tenemos el lemnisco medial, es decir, la vía sensitiva, ese es el espacio peritrigeminal. Fíjense cómo está en profundidad, ¿cierto? Entonces, ¿cuál es el objetivo de esta plática? Es que nosotros tengamos un conocimiento de toda la arquitectura intrínseca del cerebro y lógicamente nosotros podamos, ¿para qué? Para planear procedimientos quirúrgicos y que es posible hacer cirugías de tronco cerebral. Esto ya lo hemos publicado en el Journal of Neurosurgery. Afortunadamente, con buena aceptación, lógicamente ha enfocado más a los abordajes a tronco cerebral, teniendo en consideración la arquitectura intrínseca del cerebro. Gracias.
Vamos a pedir que nos prendan las luces. Vamos a dejar este pequeño espacio para que podamos ver si es que hay alguna pregunta para el doctor Párraga, por favor. Sí, vamos a pasar. Tenemos otro micrófono. Le devolveremos al doctor Párraga el micrófono, por favor. Gracias. Tenemos otro micrófono. Gracias. Ahora sí.
Thank you very much, Richard. Very beautiful.
Thank you, Professor.
For entry of the surgery you have mentioned, can you tell us actually how many crossing fiber? Which one important, which one not important? In my understanding, beside pyramid decussation, also several crossing of the fiber. Thank you.
Okay. Para las fibras, speaking Spanish, las decussaciones son importantes, principalmente a nivel de lo que es el bulbo, ¿no? En el bulbo nosotros vamos a ver de que en realidad la decussación tanto de la vía sensitiva, la vía motora, hace de que cambie toda la arquitectura intrínseca de estas estructuras, porque cambie la arquitectura intrínseca en realidad del bulbo y de ahí para todo lo que es el tronco cerebral, ¿no? Entonces, desde mi punto de vista es importante en el sentido de que nosotros vamos a ver de que tanto los núcleos de los pares craneales en la decussación se van a ir organizando, y es por eso que tal vez no se ha mencionado en el tema, en la parte del bulbo la principal variante que nosotros tenemos en la parte más superior es dependiendo a las decussaciones de las fibras, ¿no?
I think that the point of the question of Professor Eka is that you showed that at the level of decussation, you have more than one group of decussation, right? A la decussación tiene más de un grupo de decussaciones, son varias decussaciones. So probably it's variable, debe ser variable. ¿Cuántas? How much? How many?
Yeah, and for instance, pyramid decussation in the border of the medulla and cerebral cohort never touch, because once we damage, will completely permanent disability. But several small decussation, I forgot the name, of cerebellum tuber, if we cut, but sometimes the other part can still take over. That's not make any severe disability of the patient. You know, sometimes we go to the carcinoma or whatever, and then sometimes we do not intentionally, we damage the decussation. But again, pyramid is forbidden, definitely. But several decussation, I really forgot the name. And at the time, there is also a beautiful lecture from our colleague from Vienna. Yeah? And when I discussed with him, well, if we come into the brainstem, we may sometimes make a damage several intrinsic fiber, but again in the decussatio sometimes it's not very, very important, means if damage, maybe not very severe disability of the patient after surgery.
Le devolvemos el micrófono, por favor.
Igor, es complicado nosotros ver todas esto de las decusaciones que nosotros vamos a tener, decusación de Forel, hay diferentes decusaciones de las vías y realmente ya en cirugía nosotros tenemos que ver lo más importante, que es vía motora, y lógicamente al ver, por ejemplo, los angiomas cavernosos, ¿no? Cuando nosotros abordamos, sabemos que las fibras están desplazadas, tal vez no están destruidas, ¿no? Y todas esas decusaciones están solamente desplazadas, y en el momento que nosotros resecamos el cavernoma, pues no vayamos a tener mucho problema. Sí, un déficit transitorio que después se vaya a, digamos, a corregir, pero todas las decusaciones, poderlas ver en todo el trayecto del tronco cerebral, muy, muy complicado, Igor. No sé si en algún momento. Y sí. No las hemos identificado. Sí, la verdad que no lo hemos llegado a identificar, por eso le decía, ¿no? Entonces nosotros, a pesar de que la disección la estamos realizando con microscopio y todo eso, no se ha llegado a identificar todo eso, nosotros, ¿no?
¿Tenemos alguna otra pregunta más? Tenemos el otro micrófono, por favor, que les pasaremos. Ahí.
You showed for the lateral mesencephalic sulcus and approach. There was a very nice dissection where you opened the tentorium, and you said something about aspirating the quadrangular lobe. Yeah? So can you comment on that? When is necessary? When is not necessary? Maybe Eka may say a word on that also.
Cuando nosotros, depende mucho qué tanto el tentorio está abajo. 1, 2, cómo está la cisterna perimesencefálica, ¿no? Si es que nos ha tocado operar, ¿no? Quitamos, abrimos la cisterna ambiens, ¿cierto? Toda la cisterna perimesencefálica, y vemos de que independientemente el tentorio está demasiado bajo y el cerebelo, o no hay un manejo anestésico adecuado y el cerebelo está muy, muy para arriba, tenso. Entonces nosotros intentamos lógicamente abordar supracerebral infratentorial y no podemos entrar a la parte del surco mesencefálico lateral. No tenemos en el angioma cavernoso, por ejemplo, que no está expuesto hacia la superficie lateral del mesencéfalo. Entonces, ¿qué hacemos? Ya sea quitamos o desplazamos un poco, a veces no podemos porque desplazamos demasiado el cerebelo y a veces empieza a hincharse o se edematiza demasiado. Entonces comemos el lóbulo cuadrangular, un poco. No todo, como cuando necesitamos hacer un abordaje en surco interpeduncular para el pedúnculo cerebral medio. Cuando está más para arriba la lesión, es decir, tenemos el cuerpo geniculado medial, está ya pegado al cuerpo geniculado medial y el tentorio, el borde libre de la tienda nos perjudica, prefiero yo abrir la tienda del cerebelo, ¿no? Pero varía. Hay pacientes que hemos ingresado y está el surco mesencefálico lateral completamente expuesto, ¿no? Sí, pero no se ha tocado, ya sea cortar lóbulo cuadrangular o abrir tentorio, ¿no? Un corte en el tentorio, preservando el cuarto par craneano y ingresamos sin ningún problema.
Bueno, muchísimas gracias. Vamos a brindarle nuevamente un fuerte aplauso al doctor Párraga. Gracias por la exposición de la mañana de hoy. Y vamos a tener la siguiente exposición, que son las aplicaciones quirúrgicas dentro de lo que significa rombencéfalo 2, para que ya vamos a tener este tiempito para que podamos conectar el equipo de nuestro siguiente expositor, por favor. Aplicaciones quirúrgicas, ECA.
So next presentation, Professor Eka Julianta Wajapromono from Indonesia. Romencephalus second part, surgical application. Thank you, Eka.
Todavía no las apaguemos las luces, un segundito hasta que conecten, por favor.
It's different.
I can touch.
Ah, yeah. Maybe this one.
Thank you very much, Richard, Igor, for inviting us to be here. It's
Ahora sí,
wonderful-
ya estamos.
wonderful
Gracias
place.
por las luces.
Let me, because neurosurgeon is very stressful work, so that we enjoy life. Next time you come to Indonesia, enjoy with us. This is the Komodo Island. This is the last dinosaur live in the wild in Indonesia. Let's come to my place, then we can do something after surgery. So this is my group, yeah. You know, Indonesia is one of the very complicated country. We have 17,000 islands, 17000. So you know how to manage the neurosurgical center is make me headache. And this is my group. So Julius, and this is all my group. And we have a group of 22 neurosurgeons working with us exclusively. So they go to every rural area, and then we work to every day, every hour we discuss with WhatsApp. The young generation, they have to upload, and then we decide what to do. Then we can see what need to be done, and if they need the help, we will fly there. That is the best system. So this is Indonesia. You see that we are here. This is the center, the first surgery. 6 of us is here. So if they have difficulty, we fly and working together. In the beginning, we want to be the center of everything in Indonesia, but sending the patient here is very complicated. You need to fly from here to here 8 hours. So you can imagine, the better we fly there, we teach them, then someday they will independent. 270 million inhabitants, 300 neurosurgeons, 17,000 islands. Please come to work in Indonesia. We need many. So again, this is my hospital, my university, also medical school is here together in one complex. So I don't need to talk. Richard talked very good and very specific about anatomy. And again, important in brainstem surgery is we need to have an imagination, because there are many unseen anatomy. We call it the internal architecture here. Which one the safe place to enter? Like Richard mentioned, if we can identify hemosiderin from the surface, that is the best way to go. But if not, then we need to consider how to make the damage as simple as possible, because important structure once damaged means the patient will get morbidity after surgery. It's very important. Understanding nuclei and their track. So this is the definition of brainstem cavernous angioma. In our serial cases, 99% is cavernoma. We have glioma, we have TB, tuberculoma, but 99% and need special technique is cavernoma. So this is a neoplastic, considering as a neoplastic, mostly in the posterior fossa and mostly in the pons. This is the serial cases we have. We started brainstem surgery 2001 in Indonesia, and up to now we have about 60 cases. Surgical indication, when to do surgery, because it's very important to decide. Not everything we need to do surgery, but when to decide. When there is an exopitic evacuable means that we can reach for the vial surface, and progressive deterioration, significant mass effect, and multiple debilitating hemorrhages. That is the most important indication. Some cavernoma is very clear from where we need to come. but some is in the gray area. We debated, we discussing many times with colleagues in Europe, in America, whether better anterior or posterior. Sometimes that big indication. It depends on the experience and also depend on what we thinking about the gate to go. So if we go anterior, for instance, to avoid direct retract and narrow window, and posterior, select the safe entrance, like I have asked Richard about where the decussation waste, and then also wider surgical view if we go from posterior. So this is the draw, somebody from America, and I start to work together with my colleague in an MR department to make like a tractography. Making tractography the big like a spinocortical tract is no problem, right? Like a pyramid they can do it easily, but important is to do the track for the sixth nerve, because again, for instance, this case, anterior or posterior approach. This question, anterior is from here, posterior is from here. So again, we need to know where the sixth track is, because if the sixth track going like this, for instance, then of course we cannot go here. Otherwise, we will damage the sixth track nuclei. So again, important to make, we try, I think we have about six or seven cases still, not many, to make a track of the sixth nerve to decide where to approach posterior or anterior. So this is the case I told you. So this is like a horizontal track, and this is like a up-down. This is corticospinal tract, the blue one. Then we make to study again where to go without damaging the tract. So this is the cavernoma. So this is the sixth tract, the green one. Means that we go here is okay. We can save the tract of steps. You see, spinothalamic here, 6 fiber here, 6 nuclei here. It's very favorable. Need to study and where the cavernoma shift the tract. So for instance, this is a cavernoma. It's quite exopitic. Then we do posterior. Again, very important to have a good position, how to like it, and how to cut the inferior sinus, like to here, right? You just do ligation, simple ligation, 2 ligation, and then cut the inferior sinus to avoid much bleeding if we do not like it before. So just cut here. Then you see we can also leaking the CSF. Just cut here. Then we can slowly retract the tonsil, and then we use searing. You know, searing is very sharp and very cheap. We can use 100 times in the surgery with less money. We don't need sometimes very sharp arachnoid knife, but sometimes also just this also knife, very cheap. Then many times we cut firmness in the inferior side. So 1/3 inferior is okay. No need to worry about mutism. In the upper side, we need to worry about that. So again, we come here, be careful, midline. I always say that midline, this is the midline of the interior, in the intrinsic factor. Inferior, very important. So when we enter something, keep midline from the posterior fossa, because nuclei are located in paramedial, right? So after that, we can find it here. This is hemosiderin. Then you see this is the cavernoma. Then we can gently dissect here, slowly. And remember, in brainstem surgery, the entry must be as small as possible, right? So again here, this cavernoma, and then we make internal debulking as much as possible. Again, the entry must be as small as possible. Then internal debulking, very important. We need to evacuate the hematoma inside as much as possible, right? So after it's quite empty inside, then we can dissect with normal tissue. Then we can just pull the capsule of the cavernoma. And remember, we need also to consider the time, because if there's very acute, means that attack too much. We need to wait sometimes. If the patient's stable, like a bit lysis time, then everything is better. This is after surgery. This is the lady. We had the post-op 1 week later, but this is a couple of months later. So, if you need to study in the MR imaging, it's very important before doing surgery in the brainstem, yeah? So, what you decide on what you to see in the ruptured cavernous angioma. So, sometimes the bleeding is inside the capsule. So, just like the patient got like an immediate enlargement of the tumor. Then the patient come to us with sometimes sudden hemiplegia, whatever. You see, this is inside the capsule. And this has caused a mass effect to our patient. So sometimes the bleeding come to the weak wall. Sometimes the weak wall of the cavernoma and creating what's called a halo sign. You see here? This is a very beautiful halo sign. You see, like in the many picture in the Saint and Santa, there is like a halo here, right? So this is hemosiderin, and if you see this is the best time to remove. Do not miss, because if miss that, couple of months later, the halo disappear, the surgery becoming more difficult. Right? If this is disappearing, so this patient treated by neurologists in other city, they thinking about hypertensive bleeding, but not hypertensive. Then when they come to me, halo already disappeared. You can see, I will show you later. Yeah, more difficult to remove. Of course, we need to remove, but more difficult technique. So sometimes mixed density appears here. You see like a layer here. Means this is a couple times bleeding inside. This is acute and subacute. And when the best time to do surgery also need to be considered. So this is a boy with double multiple cavernoma, and then this is the anterior. I'll show you the movie later. This is subacute appearance. You see here, this is quite acute, and this is also time to remove of the cavernoma. You see here, sometimes causes severe deficit neurologic. This is the cavernoma in the medulla. Medulla is the most horrible place. You see here, and this is need also immediate surgery because the patient come with a tetraparesis, with a lower cranial palsy, with a tube, cannot eat a lot at all. So sometimes they're very small here. Of course, we don't touch, because if this is small inside, no symptom, in the deep-seated, I consider not to touch, unless many times bleeding and become larger. So I'll show you several cases. This is the case of 23 years male came to me with a quadriparesis and cranial palsy. So he is a poor man. So Indonesia, we don't have a good system of government insurance. So good government cannot make anything like this in Indonesia. So we need to create our own brain foundation. So a poor man with a good prognosis come to us, we need to do it free, and we fundraising for him. So again, you see this is beautiful halo sign. Beautiful halo sign. So the surgery is midline suboccipital craniotomy for us. So go back this question. Somebody want to do from here, somebody I prefer from here. So I will show you how, because we will make a wider exposure. And again, this is because this is the first experience of us. I prefer doing from posterior. So this is the guys before surgery, stay in the very poor house in the beach. And again, prone position. This is the beauty of pons. You see here, this is quite huge. And again, this is like dissecting in the midline. Always keep in the midline. And then again, important is debulking. And I did it unintentionally, actually. Once I got the capsule, everything moved out, just like a delivering baby. So, you know, this is the man. So we can do this tactic only if we see halo sign, right? Because the cavernoma, and this is very slippery around the cavernoma, that's again only possible if you see halo sign. So again, do not miss, because when we miss that, surgery more difficult, yeah? This is so simple surgery because of the halo. You see here, this is after surgery, the MRI, couple weeks after. And, sorry, this is the sales patient. Now he's still coming to me once in a year bringing corn and fish. He has no money. So there's a 70 years old man I told you, treated by neurologist, and a couple months later came to me. You see halo already disappearing, right? This is very clearly halo. This is disappearing. Well, I mean, anyway, because many doctors still do not understand how important about the interpretation of the MRI. Then, of course, surgery need to be done. And you see, this is the surgery. Everything is attached very much to the normal brain tissue. Then we cannot do it the former tactic before. We just keep small piece surgery. This rupture midbrain pontine cavernous angioma. We do anterolateral, subtemporal, transtentorial approach to this patient. See, this is a bit up here, and again, you see here there is a small halo, not completely halo. So this is the hiatus. You need to understand the anatomy here. Again, we need to drill the temporal bone, then we retract a bit the temporal lobe here, you can see here. Then I need to cut the 10 here, right, to make a bigger exposure. Then you can see here the sixth nerve that you can see we can dissect to the lateral side clearly. And then you can see this is the hemosiderin here. So again, important is to find where is the entry zone. If you find the color like hemosiderin here, even small one, means this is the safest, because this is the closest part to the surface. You don't need to damage to the other place, right? So again, coming here slowly, and then internal debulking, and then remove from the surrounding parenchyma. And again, this is the good time after some of the hematoma lysis, then it's easier. Otherwise, everything is attached to the normal parenchyma. So just slowly. And then if you need to do bipolar, must be very, very, very low. Be careful. Yeah, sometimes when I very rare use that, but if necessary, again, very, very low bipolar, because it will destroy everything. So she's starting one day in ICU. So that's make happy, because swallowing is big problem for the patient. So this is another case of pontomedullary junction cavernous angioma, but located quite superficial. You can see here. Then again, the surgery, of course, not so difficult, just opening again from the posterior. We love posterior very much. So you can see here, the brown area means hemosiderin at here. Then we can just do here with a micro scissor. Then we just remove all of the cavernoma without any problem. You can see here, because also the size is not so big, because we can cut very clearly here, slowly. And then again, total removal is the goal of the surgery. So slowly here, and then remove everything. So important, because again, the eye movement, once we touch the sixth nerve, then the patient becoming double vision forever, right? And there's a similar case you see here, but the location is deeper and more to the medulla. You see here, this is pons. Pons is the biggest part of the brainstem, right, as with your thumb. And you know, medulla maybe only one third of the pons. Is that correct, Richard? Medulla is 1/3 size of the pons. But you see the nuclei, here is so crowded with many nuclei, right? Here is okay, but not so crowded. Important. So again, touching medulla is much, much more dangerous, because again, this is all the small volume, but everything is included here, and very complicated nuclei. Anyway, we need to do surgery again, and again, this is a big vein. Be careful. Do not touch the big vein. Then we go enter here from the midbrain. Here, the patient need to use tube about 2 weeks after. Normally, if I share with my colleagues from the US, after medulla surgery, always use tube. But hopefully, only temporary, because permanent is terrible, right? You can imagine that for long life, you use tube here. Anyway, if you do here, you must touch at least the nuclei of the lower cranial nerve, better touch, but do not damage, right? Because damage means permanent. So this is not the case of ruptured ponton cavernogioma, ruptured here, you see, ruptured inside the capsule. Means that the young girl came to me with immediate plagia, you see here, anterior or posterior. I prefer posterior again. So stria here, you see, stria medullare, and again, cutting here, keep midline. So again, this is discussion, yeah? Somebody do not agree with me, I prefer anterior, I don't know, I prefer here. Because here again we have like a more wide surgical field. Again, slowly piecemeal removal, slowly, and again to do it here, important to have a good microscope because we need to see so many angles. Yeah. So after surgery, just after surgery, and this is the girl 10 days after surgery, still paralysis in the left side. And this is 1 month later. You see, in children, indication is much more better because children recover better and many times repeating bleeding. So in children, it's more indicated for brainstem cavernous angioma. This is a boy, 9 years old, with a sudden onset diplopia and walking difficulty. If you see here, I thought that was only one ruptured cavernous angioma in the posterior pons, but it was a small in anterior. I did not see. But anyway, the first ruptures in the posterior side, then we decided to do, again, posterior approach for him. Right, you see here. You see also many layers here, many layers. So once you open from here, you will meet the cavernoma first and the hematoma in outside. Again, splitting vermis. 1/3 inferior is quite safe, right? Otherwise, if we do not split and location is too up, we need to retract too much to see the up, right? This is the cavernoma. Then we just cut here the cavernoma, slowly, piecemeal, again, until we found hematoma beneath this, right? That was a black oily hematoma. This is the boy. Just couple days after surgery, and he saw me in the clinic quite regularly. And couple of months later, found here that hematoma, another bleeding in the anterolateral side. You see here, it was not appear, but now becoming bigger and more bleeding in the anterolateral side. Then we do the second surgery 1 year after. This is again from the subtemporal, again cutting the diaphragma here. You can see here. Then this is the cavernoma, right? Normally we can see, right, this is the cavernoma, it's very clear. Then it's not so difficult also to dissect from the surrounding tissue. Then we can just come and internal debulking, and this is the boy after surgery. This is not paralysis because he fell down after playing soccer. And he is now already in the intermediate school, and he is a very nice boy. This is a subacute rupture medulla exopedic cavernous angioma. You can see here, this is exopedic. Exopedic means not so difficult because we will not enter the medulla. You can see here, this is the anatomy, spinal cord here, lower cranial here, and vertebral artery here. Right? Important is to make a better anatomy imagination here. Right? This is the lower cranial nerve here. Again, medulla. And this is the cavernoma. You can see here. This is exopedic. Then you can see from outside of the superficial of the medulla. Then again, just dissect slowly for the normal tissue. And then again, just cut here. And then just make an internal debulking. It's very, very important. So again, important is to have microscope. You need to see very extreme angle because we cannot retract at all brainstem, right? So microscope must be a good angle going everywhere. Again, this is piecemeal removal of the lesion. Be slowly, and again, we can see another angle and nothing left behind. So clear up everything, Make sure there is no bleeding source. This is 1 day after surgery in the ICU. This is the man. It's important not to have a paralysis whole move. So this is another case of 42 years old male with hemiplegia and lower cranial palsy. You see here, cavernoma is in the medulla. This is again the most horrible things. How to approach this problem? To where? Because again, you cannot go from here, right? A corticospinal tract is in the anterior. So anyway, midline. Midline is very important. This is not appear from the surface because the hemosiderin doesn't reach the pia. So again, straight to midline, right? This is just remembering the anatomy, like Dr. Richard showed us. Again, midline, very important to go midline. I'm scary because near here, paramedian is many nuclei, right? Midline from the posterior, I don't think there is a crossing here, Richard. There's no crossing in the posterior part in the medulla, right? You agree, right? So again, coming here, be careful, slowly keep in the midline. Then finally, we can find cavernoma here. This is just about 2 millimeter beneath the surface. This is not easy, really not easy, because again, this is very small medulla size, you see. This is the cavernoma. We find the cavernoma here. Be very careful, slowly, because again, this is a very small volume of medulla. Slowly here, coming here, many important structure, many lower cranial nuclei here and tract here. Ooh. And beneath that, of course, corticospinal tract is there, decussation is there. So very important, keep that. And he used 2 months after surgery. But anyway, after 2 months, oh my God, 2 months. 2 months is not bad because again, this is medulla. So fortunately, not permanent disability of swallowing is very important. You know how suffer someone cannot swallow. So this is post-op MRI, and this is another case of male hemiparesis with a midbrain cavernoma. We take it from subtemporal approach. This is all not special. This is lower pons cavernous angioma. We do pre-sigmoid approach. You can see here. This is the cavernoma, bleeding cavernoma. You can see here. Where is it? So you need to remember from where the cranial nerve we will go. Again, coming here from the retrosigmoid, very important to lick the CSF, right? We need to lick the CSF by cutting the arachnoid like this, okay? So you can see here, this is lower cranial complex. You can see here, this is 7th nerve. You need to remember that the closest part must be in the cliff between the 7th nerve and lower cranial nerve, right? You see here, you can imagine like a brownish beneath the surface. You can see here, that is the closest part of cavernoma. So if we enter from here, again, we need to debulking. Again, this is a quite narrow cliff between 7th and lower cranial nerve. So coming here, be careful. She is a very poor employee from other island. Then she cannot swallow at all before surgery. So after surgery, immediately can swallow, but still need times to recover the hemiparesis. When she came to me 6 months after going to her island, she already walked. So again, important to see and to study where is the entry point. So again, this point, you cannot see hemosiderin from the surface. Then we need to know from where the cliff. So the site, in this case, is the cliff between lower and 7 and 8 complex. So this is the last, this is our experience on behalf of Professor Benes. We do like a 3D cinema lecture. This is interesting. Next time we can make in Bolivia. Yeah? So lecture is in the cinema. In the cinema, and 700 participants. So they use like a spectator, like to see Nemo. We can do it also in Alicante. Yeah. So next time again, enjoy after very stressful surgery. enjoy life. Yeah, coming to Indonesia, enjoy the best underwater in the world. You can swim with him. Okay, thank you very much for your attention.
Thank you very much, Professor Raika. Wonderful presentation. Questions? Comments? Richard?
First, congratulations for the wonderful lecture. I enjoyed a lot. I have seen in Brazil some colleagues, they are managing some brainstem cavernomas with propanolol. Have you seen that? Have you read something about it? The first question. And the second, I have seen some colleagues in Brazil, they are managing some cavernomas, brainstem cavernomas, usually the ones that doesn't reach the surface, the PL surface, with not a clear history of rupture. They are managing with propanolol beta blocker medications. If you have, Professor, some experience with that. And another question is, okay.
Sure, I'm sorry.
Sí, se lo pueden revisar el micrófono, por favor. No está funcionando, creo que tenemos problemas con las pilas y con las baterías.
Sorry. So I have no experience about propanolol. But again, in brainstem cavernoma, again, most important is to decide what is the indication. If the cavernoma is not big, no clinical symptom, no rupture, I'm thinking to remove it. You're right, non-ruptured, I think almost all of cases are ruptured. Because when they are non-ruptured, I don't think any symptom, in my experience, in my cerebral experience. Again, indication very important. I don't know the reason, maybe you know why they use propanolol, I don't know, is something a heartbeat or not?
No, I have seen some, they are managing with propanolol. They have seen something in the literature, and for selected cases, they are managing like this.
Elias, you have experience about propanolol? I don't know. Because if there is symptoms, I don't see.
No, there's a recent article which has come out, published by the Burn Group, that looked at profiles of patients using propanolol. There is, I think it is just natural history of the disease.
Okay.
Honest, to be absolutely honest with you. I've never tried it.
Okay. The second question is, what is the main difference between a telovelar approach with the resecting the inferior part of the vermis? Is there a difference of field, a visual field of, why not a telovelar approach? How to choose the approach?
Yeah, very good question. It depends. I mean, if you go to the pontine cavernoma, so depend, is it the lower part, like the last show, we don't need, of course, to do anything. But if this is quite up, you cannot only telovelar. Telovelar means that your microscope has to go down like this.
Yeah.
Right? And then it's maybe dangerous also the anesthesiology, maybe will influence the venous return. I again prefer to cut lower part of the vermis, means that you can split like this.
Okay.
And you can see my first case is a very beautiful white exposural pons and nothing happened. In my experience, depend. Again, if the location is quite up, middle to up of the pons, we need to split vermis. My personal opinion.
Okay.
Right? Telovela, again, you need to, because it's too long.
Are that patients sitting or?
No.
No. Okay.
I hate sitting.
Okay.
I don't know. My personal opinion, I did a couple of times. One died because the emboli. So I hate it. A pure prone position, I don't think any problem.
And all done with physiologic monitorization?
Yeah.
Okay. Thank you very much. Congratulations.
¿Alguna otra pregunta para el doctor? ¿No hay más preguntas?
Any more questions?
I enjoy your hello sign, and I'm using the term now. Probably I'm only one. In my mind, it's sometimes between 10 days to 3 weeks. Am I right? Sorry? I always prefer to operate on brainstem cavernomas on a semi-elective basis. Never emergency, because you cannot quit stop bleeding as in any intracerebral hematoma. You have this hello sign. I wait somewhere between 1 to 3 weeks, then go for surgery. What's your, you said hello sign, you didn't give any figures, any timelines.
Yeah, I agree with you. In this options, you are my friend. So, I mean, if the condition is stable, is not worsening of the clinical symptoms, patient fine, I agree with him. Better we wait. Why? Again, because the first day of bleeding is still heart hematoma, right? In the second, third week, becoming lysis. Lysis means, of course, easier to remove to internal debulking, and of course, if there is an anterior, it's easier. I agree with him. Completely agree. But again, watch, because we also observing one patient in the fifth day, becoming more deficit neurology, become difficult to swallow, and then we cannot wait. But if everything's stable, I agree, because wait until the hematoma lyses better. No worry, you can have 10 more.
Do you think that in the case of the little boy, neuronavigator could help to reach the lesion that left? The boy with the left cavernoma, a neuronavigator could help you identifying the lesion in the first surgery?
Yeah. So the boy, if you see the first MRI, so the bleeding is the posterior side, yeah? I did not pay attention, honestly, that there is a small cavernoma in the anterolateral. And that's becoming bleeding a couple of months later. If I see that, I will also not doing anything in the anterolateral side, because the symptom coming from the posterior side. So again, if the anterolateral, for instance, not bleeding, maybe I don't touch. So that is the reason. I mean, we cannot go here and then here in the same surgery. I don't think so, unless that is very urgent.
But neuronavigator during the first surgery,
Mm-hmm.
do you think that could help you to find that lesion?
No. So again, we only go to the lesion of cavernoma. Never go down more. If you go more, you need to destroy important structure. No. I don't think so. So again, important is again, if possible, do not go any normal brain stem tissue to remove cavernoma, if possible. So again, if there is like a sign in the PR surface, always from there, in my opinion. If not, you need to select the very safe. So very safe means not damaged at all. Because when you see Richard's lecture, you will be confused. So many completed inside, then you cannot go enter. Anyway, select which one that's not more morbidity after surgery. That's more important.
Sí, ¿alguien más?
Yeah, I agree completely with Eka that in those cases, neuronavigation has very little to contribute, because with the brain shift and in the cavernoma, in the stem, a difference of 1 or 2 millimeters is crucial. And if you have a 1 or 2 millimeters error with your neuronavigation due to shift, it becomes virtually useless. But my question was for actually Vladimir. I mean, where is the value of intraop MR for these things? Because with all the blood and blood products, are you able to differentiate residual cavernoma from blood and blood products due to surgery?
No, there is no reason for intra-op MR in brainstem cavernomas at all. The reason for intra-op MR are deep, lobar, small ones which you need to operate, and it's seek and find mission. Once you get nervous that you are still dissecting and you are not hitting the cavernoma despite all the navigation, then it's best to enter the intra-op MR and go for it.
And the question of the remnant.
Of the remnant, I don't believe you could see it on intra-op. You know, it's not that easy to evaluate intra-op images. I will show them in a while, and it really, we've got it more than 10 years, and still we have lots of troubles. Yeah. Eka, one more question. You never mentioned venous anomalies. In brainstem cavernomas, in my experience, there always is one, and that is why always before surgery I seek it actively, and the same during the surgery. I actively look for the venous anomaly, and that's, I think, one of the most important parts of surgery, to be sure that you do not damage the vein. What? No, I would kill the patient.
I agree. Unfortunately, actually, last 2 weeks we got a very beautiful venous angioma, small cavernoma with very big venous angioma, but I did not have time to edit it. Yes, I agree with you. So, but I never looking for where is the venous angioma. Of course, somewhere there. But if not bleeding come out, then I don't touch.
That's one of the most important marks which approach to choose. The venous angioma, venous anomaly, let's call it that way, is I always try to come from the opposite way. So it's one of the decision points at the very beginning, which approach to choose. Because there always are several routes to the cavernoma.
Yeah, agree. So I mean, I think Visnamba forgot that we can see like a big vein, then of course we avoid. Yeah, thank you very much.
What about those sharks? Are they dangerous?
No, you can touch. Next time. Our
friend. Any more questions? Thank you. Thank
¿Más
you very
preguntas?
much.
No. Vamos a brindarle un fuerte aplauso, por favor, al doctor. Muchísimas gracias. Ahora sí, vamos a tener un receso de 10 minutos. 10 minutos, por favor, para el refrigerio. En 10 minutos les pedimos, por favor, estar de vuelta aquí en el salón principal para continuar con las siguientes exposiciones. Vamos a invitar, por favor, a nuestros expositores que puedan pasar aquí a la sala VIP para que puedan estar en el refrigerio, y a los asistentes a la entrada en el lobby, por favor, para que puedan recoger sus refrigerios. Reiteramos nuevamente, por favor, en 10 minutos aquí en el salón.
10 minutes break, please. 10 minutes.
Queremos recordar a todos los asistentes que después de la conferencia, de las conferencias que vamos a tener la mañana del día de hoy, vamos a tener el receso para el almuerzo, y pedirles por favor que esta tarde a las 2 de la tarde, 14:00, vamos a dar inicio a la parte práctica de este curso. Entonces, por favor, 14:00 en los laboratorios de morfología, donde estuvimos ayer en la tarde. Entonces, 14:00, por favor, en morfología, para tener la disección de cerebros. Nuevamente les reiteramos, 14:00, por favor, después del receso al almuerzo, para que podamos dar inicio a la disección de cerebros en morfología, por favor. A continuación vamos a tener la exposición de rombencéfalo 3, aplicaciones quirúrgicas. Entonces vamos a recibir, por favor, al doctor Julius Juli para que podamos continuar con las exposiciones de la mañana del día de hoy.
So we'll continue in second. Sorry for the program. Second part this morning. So the first lecture of the second part is with Dr. Julius Julai from Indonesia. Thank you for coming, Julius. Third part of rhombocephalus surgical applications. Please.
Good morning, everybody. Thank you for Professor Paraga and Professor Maldonado for the invitations for us to be here to share our experience. So, yes?
Yes,
Yes, perfect. So, my talk will be just the applications of the What happened? Is it coming? Yeah. The applications for surgery. No, I don't need it. Yes, I can do it. So it's directly to see the cases and then see what we can learn it from the case. The first one is a 59 years old female that presented to us with 1 week history of headache and become drowsy for the last 3 days prior to admissions to hospital. And then 1 episode of vomit during the hospital. And it's obviously, if we can examine, we see that obvious nystagmus. And this is the picture of the MRI, T2. You can see that. It's very obvious that something going on for the cerebellum side. This is on the left, if you can see that. So it's bring us to the differential diagnosis, what it is. This could be bleeding because it's sudden happening. It could be tumor bleed. It could be more commonly things like this. So this is a flare, as you can see that. This is T1, this is T2, as you can see that. This is T1 with contrast. So, take a look at the picture. If you take a look at the picture on T2, we know that there is a bleeding, and then it's probably multiple bleeding because the image is so typical picture of multiple bleed of capharnoma, because the blood inside is in different age. So we decided to do surgery because she was so sick, so drowsy, and sometimes very difficult for her to open eyes because she's feeling so much dizzy and headache. So how can we approach this? We do it in a simple way. So this is the positions of the patients. You can see that this is the plan of the cut. And this is a video that we can enjoy it. So after we open the skin, and we make a small craniotomy, as you can see that. At the beginning, we will see that the cerebellum is tight, but don't worry. Once we get into the blood clot, the blood that lyses, and then we can decompress it. And we keep continue separate between the capharnoma and the cerebellum, and make sure that we get everything out. And at the end, we can see that it's so relaxed after we remove the capharnoma with the blade. And then we start to close. And this is the, and this is the post-op scan the next day. You can see that. We keep watching this lady because we also worry that there is a small little chance that the cerebellum can swell. And if it swell, and it's good causing hydrocephalus, luckily not this case. So if we take a look at the cerebellar capharnoma, I think capharnoma have a wide spectrum. Some of the capharnoma find coincidentally during the MRI never bleed forever. If you follow them, they never bleed. Should we take out this? No. Some capharnoma will grow in size, never bleed, but they grow. It's less like tumor. So this kind of capharnoma maybe some days cause problems. Typically seizure, so we need to remove it. Some capharnoma may bleed, first bleed, and after that, they never bleed again. So we take it out? No, just follow it. Because the natural course of the capharnoma bleed is they get worse at the beginning. It's a slow flow bleed because it's coming from capharn. It's not arterial bleed. And when they get worse, they will get better because by the time they will be absorbed, the blood. So the one that we need to put attentions and need to take actions to remove them is the one that repeatedly bleed. So this is the one that making the patients worse. And if you look at the cavernoma on the cerebellum, they actually behave good, and surgical morbidity actually is very low. So it's good lesions, and it's over cure. So this is a kind of typical pathology, as you can see that, if we get it report back from the pathology. This is post-op 1 month. Unfortunately, we don't have long. This is a recent case. This is how it looked like. We still have a hemosiderin stain on T2, as we can see that. So we just need to keep following them. Second case. This is 54 years old female. Come with imbalance, nystagmus, have a headache on and off. As you can see that, if you take carefully look, you can see that a cyst on the cerebellum, and then the contrast side, if you take carefully look, this is the problem. Small little knob on here, okay. So that small little knob is the problems that we actually have to remove. So surgery, we make a small little craniotomy. We can see that this typically red on the surface, and you have a big vein here. This is a typical picture of hemangioblastoma. Even before the pathology come out, we can predict it. So the feeder is usually very small, little subpile feeder. So we need to isolate them from surrounding. And the last part, we need to cut the vein. And then it's finished. When we send to the pathology, so this is a post-op MRI, as we can see that. That little knob is the problems that create the water making the cyst. So the pathology consistent with what we expect. This is hemangioblastoma. This is another case. 40 years old, again female. He did the first surgery in 2009, other surgeons. The pathology proved that it's hemangioblastoma, so I guess it must be bleeding during surgery. And on December 2012, she was referred to us because of multiple episodes of vomit, occipital headache, and then unable to walk because of imbalance, and the feeling like passing out. So this is during surgery. As you can see that. So we open up. And for hemangioblastoma, I think surgery often offer cure to the patients. So we need to really pay attention, not leaving anything behind. Because if we leave something, it will grow back. So this is separate and isolate the tumor, shrink it, and do not pull anything. So this is after the surgery, as we can see that. So this is post-op 3 months. And then this is after 3 years. So I think even benign lesions, we need to keep following them. It is not done if we just do the surgery and the next month we say that it's done, you go, don't come back. Follow-up is one of the key factors that we need to realize is very important. So for cerebral hemangioblastoma, it's proof that this is pathology consistent. They are often cystic. Why? I think the pathology, the pathobiology of this is because they have a high pressure of the vein. The feeder is small, the subpial, and then they accumulate and they drain out to the veins. So the water actually that happen in the interstitial side, they cannot really well drain out through the draining system, the veins. So they're keeping there. And then the aquaphorins, by the study, have proved that they will scavenger and make a small cyst. In the future, they condense, become a big cyst. That's how they oftenly found with cyst. Do we need angiography? Most of the time we don't need. Unless at specific locations we worry about abnormal vessels. So we need to do CT angio. Mostly located dorsal, and they are good prognosis for non-syndrome 1. This is another case, 32 years old, female, headache, imbalance. It's also proof that she is hemangioblastoma. Look at that. She has these homogeneous enhanced lesions with cysts surrounding it. And this is after the surgical removal. This is also another case, 54. This male, headache, imbalance, vomit, and then also proof that it's hemangioblastoma. It's another case. It's not typical picture of hemangioblastoma, but it's also proof that during surgery and the pathology consistent with hemangioblastoma. What about this one? 27 years old, male. And then he got these lesions. He got 2 prior surgery. Second one was done in November 2010 at another hospital by other surgeons to decompress the cyst only. He came to our clinic in February 2011 with imbalance, couldn't walk properly. And he got this picture. The cyst with homogeneous small lesions. And then we have predict what is the pathology is. So we consent, and then we did the surgery. So this is during surgery. We try to manage and aiming to the lesions, slowly cut it, and divide it from the surrounding brain tissue. So finally we can clear it from the surrounding brains. And we need to do it gently, so it doesn't cause remote injury. So this is after we remove the tumor out. And the pathology consistent with hemangioblastoma. This is the MRI show after the surgery. Is it cured? Not for this one. If you take a careful look, this one, you'll see that's a lot of little spot, white, contrast enhanced, even especially at the cerebellum. So this is a typical picture of Van Hippel-Lindau disease. So this is a syndrome. We cannot remove everything because it's in the gene, the problem. So we need to consent and tell the patients that it might be you need another surgery in a few more years because there might be a chance that these small little things will grow and cause problem. So this is 2010. In March 2014, he come back with problems. As you can see that small little thing is growing, and this one causing problem. And then we decide, oh no, sorry. This is 2014. We know that it's growing, but it's not symptom yet until June 2016. And we let the patients know that we only do surgery when you become symptomatic because we cannot cure him. So it's totally different approach between the sporadic hemangioblastoma and the syndrome one. Syndrome, you have to be careful. You cannot cure them because they're always in their gene already. So this one, come back, it's 3 things, and then small little knobs. And this one is the one that producing the water. So we have to remove it. So this is a second surgery. So we open up, and then we resect some of the cerebellum to get into the cyst. And we do circumscribe dissections slowly. And remember, dealing with this, do not pull anything. It's very important to do it circumferentially and gently. It's a beautiful surgery, in fact. Once you get it done, it's beautiful. So this is after the surgery. So this is post-op. This is another case. Interesting one. So 25 years old, senior medical student, he was shunted in another hospital 4 weeks prior to admissions to our hospital. They did VP shunt and aspirate the cyst. They thought it was a neuroglial cyst. Okay. He get better for 1 week, then the symptoms reappear with headache, vomit, cerebral signs. And then the father was, his father is actually an ENT surgeon. And then they come to me, come to us, Professor Eka, and then we try to study the picture. We think that it's impossible that the cyst coming by its own. It must be something that producing the water, they accumulate. They miss this little knob. Be careful. Look at this one on the bottom. They miss it. So this is the cause of the problem. You cannot just aspirate the cyst. It will keep coming back. So the surgical strategy, we need to aim to that little nodule. That's how we can cure him. So this is during surgery. We can see that this red mural nodule sitting here, and then we need just to take it out. It's small, but it's causing problem. So we dissect it slowly. Dissect it slowly. And cut it when it's necessary, slowly. And we preserve the PR, the surface vessels, as we can preserve it. Anybody can guess what is the pathology? Yes, absolutely, pilocytic. So this is a typical picture of pilocytic. Okay, I think if we can follow them, majority of them never grow back, the tumor. So this is right after surgery, post-op, 3 months. And this is also recent case. This is 6 months. Yes. So keep following them. This is another case, 11 years old female, 2 prior surgery in another hospital by another surgeons. They remove a tumor. I guess they're coming from the midline. This is the initial incisions. And then they put a shunt, I think. A second surgery is they put a shunt. It's probably they didn't remove the tumor totally. So this is when she came to our clinic. And we can see that there's 2 little knob on the side. So we decided to remove it. She was wheelchair bound for 6 months before come to our clinic. Severe imbalance, often fell while trying to walk, difficult, even in drinking, especially in drinking water. I think drinking is more difficult than swallowing a solid food. So this is the picture. We know that. This is the plan of the surgery. We have to tailor with the old incisions. I don't know how to do it. And then we see that there's another incisions here. So we tailor it like this one, the incisions. And we use these old shunts as a guidance because it's just sitting behind and posterior to these 2 enhanced nodule. Let's see. So this is during surgery. We intentionally do not remove the shunts, just leave it there as a marker for us. So we go inside the cyst and then we can find the tumor. So we gently removing it, use a scissor and do not pull anything. And then once it's done, then we can remove the shunts for the cystoperitoneal shunt. So that's how it looks. And then we need to close it tightly. Sometimes we have to put the muscles and glue because it's old, because it's previous surgery. And the pathology show that it's pilocytic astrocytoma. This is first day after surgery. So you can see that. She can walk by her own. She was wheelchair-bound before. So this is immediately post-op MRI. So post-op MRI is an option for patients and family. We usually offer them. If they want to do it, they can do it within 48 hours. Otherwise, I just postpone it to 3 months. 3 months is a must because that's the baseline. In between, we will have a lot of surgical artifact. So this is after 1 year. She lives in very far away. This is in Papua Islands. So the parents send it by WhatsApp. So nowadays, it's easy to follow the patients just by asking them, sending a picture, make sure that they're good. So she's working fine. So we're happy with that. There's another case. 10 years old female, headache, imbalance, and vomit. What is the differential diagnosis? You can see that. It's probably hemangioblastoma. It could be pilocytic astrocytoma. So anyway, we have to remove this enhanced nodule. What is the prognosis? I think the prognosis is good. And this is immediate post-op within 48 hours. You can see that. And then it turned out to be pilocytic. This is 5 years. We keep following them. I'm sorry I don't have the reasons. This is 9 years. And this is C now in university. You know, she's in university now. I think this last one. 4 years old girl with imbalance, multiple episode of vomit, typical picture. So it could be medulloblastoma, ependymoma, that's most likely. So we need to take it out. So this is during surgery. Germinoma is unlikely on these locations. This could be in the list, but the chance is low. The most common one at posterior fossa for children is medulloblastoma, and then ependymoma, and then pilocytic, and then the other one is diffuse pontine glioma. That's common one. So at the end of the removal, you can see that this is the aqueduct. So this is after surgery, the MRI. So it's proof that it's medulloblastoma. Well, this is another case, same one. That one, the first one, until today is still clear after the radiations. No chemotherapy done for her. She still show no recurrence. This is another case, 14 years old, cerebral sign vomit. So we removed this tumor. It's proof that it's medulloblastoma, doing well after chemo radiations, then recurrent with drop meds, tetraparesis, and die 2 years after the recurrence. So what is the difference? Nowadays we know that for medulloblastoma there is a subgroup of them. Some of them behave good, some of them behave bad. So I think that's what I can share. Hopefully we can learn something. Thank you.
Thank you, Professor July. Questions from the audience? Where?
Professor?
Vamos a pedir que nos prendan la luz, por favor.
I enjoyed a
Ahora
lot
sí.
the lecture too. I have a doubt. You said that some cavernomas, it will never rupture, never bleed. Do you think that the natural history of the pathology, it's a clinical rupture, that a symptomatic rupture, or do you think that cavernomas always will bleed, but not always will be symptomatic, a clinical rupture?
You will easily know whether they rupture or not by looking at T2 MRI. If you can see the hemosiderin stain, it ruptured before. If you didn't see it, never ruptured. Some of the cases, they don't have hemosiderin stain. So it doesn't rupture anyway. So you just keep following them.
Okay. Yeah. Another doubt. In some cases, I saw a very huge hemangioblastoma. I saw the craniotomies are always just in the cerebral hemisphere. You don't try to get some liquor, some liquor, CSF from the magna cistern.
Yeah. I think if they have a cyst, easiest way, you make sure that you don't puncture the hemangioblastoma, but you puncture the cyst at the beginning. That's the easiest way.
Okay.
Okay. If you don't have big cysts, you have a big tumor, then you can give a mannitol, even lumbar drain. That's easy. It's not difficult.
And
if you need space.
The last one, what is the trick? In my hands, hemangioblastoma, it's always a lot of blood, a lot of blood. It was a very clean surgery, a beautiful surgery.
Have to be clean.
What's the trick?
The trick, the feeder is always small. The big one is the vein. All little ones, like hair, even smaller than hair, is the feeder. So you go and separate them, even for the spine. I do a lot for the spine. It's easy. You shrink it. The big one, don't touch. Leave it for the last. You don't try to cut the big
Just like AVM.
because that's the vein. It's very easy for hemangioblastoma because the big one is the vein always the time.
Thank you very much.
Julius, you were just saying about spine. In von Hippel-Lindau syndrome, for example, you may have several of them, and they are all one beside the other inside the canal. So it may not be very easy because you have vessels, dilated vessels, and so I think that's the main question, because sometimes you're going around, but you have a bleeding. The bleeding is not from a hemangioblastoma directly, but
The main vein. Always when I'm doing the resection of the capsule, near the nodule, the enhancement point, bleed. To me, it's always a difficult surgery. I saw these wonderful clean surgeries. I'm doing something wrong.
In my experience, you have to be clean all the time because I think the principle is just similar with AVM. You cut the wrong veins, terrible. You have everything just pop up. It's crazy if it happened in spine. For spinal cord, typically, most of the time we find actually at the posterior. So it's usually, we can see it from the surface all the time. By having a small little coagulations, you shrink it actually. And then you create a space between the tumor and the cord. And then don't pull anything. Leave the big one at the last part. Make irrigations to avoid heat injury.
Is there a hold for green endoscopy in this kind of surgery?
I don't think so. You use it?
Yeah.
If the vein is not too arterialized, which is rarely the case, it usually happens in AVMs, but for hemangioblastoma, the vein is not very arterialized. So on ICG, you can see it. You can clearly make out the vein. And just to be absolutely sure, before I cut something large, I always put an aneurysm clip. And in hemangioblastoma, if you have put a clip on the vein, it increases just before your eyes. It keeps on growing much faster than the original lesion. So aneurysm clips and ICG helps. Yeah.
Bueno, muchísimas gracias. Vamos a recibir,
the
por
most
favor.
important is to avoid entering the hemangioblastoma. It doesn't matter in cerebral ones, But spinal cord ones, CC junction, these, they are much worse than AVMs. In AVM, if you enter the AVM and you have bleeding, you can control it. Not in hemangioblastoma. You never stop it.
You know, this hemodynamic discussion, I think is really important. You know, I use it to do angiographies. It's not indicated, of course, in every case. But there's something very interesting that when you inject contrast, you see very rapidly the hemangioblastoma. And then you start seeing the veins and the venous return, but the hemangioblastoma is still there. It has been described also for other types of tumors, for meningiomas, for example. There is a funny history about this, because of this phenomenon for meningiomas is being called in some books as the mother-in-law sign. The mother-in-law sign, because when she arrives, you are not expecting her, and she takes a long time to go away. You know? My last question is for von Hippel-Lindau syndrome, von Hippel, ruptured, but you have a second one with maybe feasible with the same craniotomy. Would you go for the second one? Yes or no? Why?
You mean the second?
Hemangioblastomas. Yeah.
So for phacomatosis, the group of disease, including von Hippel-Lindau, neurofibromatosis, we treat the symptomatic lesions all the time. If they don't show up the symptoms, we just follow them. We never cure them. So if they symptomatic, we treat them. And one more thing, in spinal cord, we need space. Sometimes, yeah, don't go inside. But sometimes we have a big one. We ever have 3 levels of hemangioblastoma. So what should we do? We need to separate into 2 pieces. So you keep coagulating them. I never use ICG, but I think if you have, you may use it. Indocyanine. Yeah. We have indocyanine, but we didn't use it.
Julius, fully agree with following these patients. Question number 1, how frequently do you call them for MR?
It depends. If we are comfortable, this could be every 1 year for a few years, and then every 3 years, and then maybe every 5 years.
And now the spinal cord ones. Say you have 4 or 5 of them within the spinal cord, you follow the patient, and the patient is still asymptomatic, but one of the lesion grows.
That's a difficult question. Yes, I know.
It's better to start before symptoms.
Yeah, if they are syndrome, I will prefer to wait. If they are syndrome, it doesn't make sense just to rush and take out some with surgical risk instead of just to watch them. You will never cure them anyway. Like neurofibromatosis, you know that there's so many there. Some will grow, some suddenly stop for a few years, and then they grow back again. You never know. So I prefer to just more conservative wait and see. Thank you.
Bueno, muchas gracias. Vamos a
preguntas?
recibir a continuación
Muchas.
al doctor Vladimir Benes con el tema evitando complicaciones en la sustancia intrínseca hemisférica durante la cirugía cerebral. Recibimos con un aplauso, por favor, al doctor Vladimir Benes.
Thank you. First of all, thanks for inviting us and for having us here. And hospitality great, place excellent, the dissections, I hope you've enjoyed that. When we were starting with the program, Igor gave me the task of complication avoidance in intrinsic tumors. This is not really the topic I do much, the intrinsic tumors, but we have intra-op MR, and we prospectively follow. Doesn't work. Follow all the patients. So we have a large database over the past 10 years. And thus I checked the complications of those patients with supratentorial gliomas, low grades, high grades, but supratentorial only. Okay, so I'll do it by hand probably. Yeah. And this is along the lines with Keketurel, what I realized. I have seen it all. Any complication you could mention, Yeah, I have seen it. It's like, especially in glioblastomas, it's like Murphy's Law. Whatever can go wrong, it does go wrong, unfortunately. So this is our setup with intra-op MR, which is excellent for low grades and very helpful in high grades. This is the regular OR, and we just open the door and go through the door for the OR, then we close the door and the outpatient flow goes on. And this is what we had over the past 10 years. It really is prospective study and very honest. I will show you a few instances where we really evaluated very strictly. Starting at 2008, there was 600 resections in 539 patients. So this is rather a huge number which we can use. And what it looks like usually is like that. This is a regular glioblastoma, which we all know. This is the intra-op MR with which we are happy. And since we do not continue surgery, this is not intra-op, this is immediate post-op. Because we are down, we just close the wound after that. And this is the MR which we always perform within 72 hours after the surgery. With no respect to intra-op MR, always within the 3 days and then 3 months. And all those radical resections, which we consider radical, are really radical. That there is nothing. Not near total, close to total, subtotal, and supramaximal, whatever. Really total, that there is nothing on MR. The goal of surgery in gliomas is to relieve symptoms, preserve high quality of survival for a limited time span. That's important. You probably all know that the theoretical people, they love glioblastomas because they easily evaluate them. So whenever we have a glioblastoma, there is 5 or 6 people from various labs waiting for the tissue sample. They do not want any other tumor but glioblastomas because they are, unfortunately, still fast. So what were the results, what we did achieve, and what were the complications, which is most important? In both high grades and low grades, the radical, but true radical resection in half of the patients, which I think is rather nice and rather successful, but these were really the radical resections. Where we intended to perform radical resection, we evaluated this in advance, it was 83–85%. And we continued surgery in 38% of cases. It means that in 38% of cases, the original resection was not really enough. The complications in this series, and that's important, that's what we need to talk about. 94 cases, it means 20% had any kind of complication. CSF leak, wound infection, epidural, small intracerebral, whatever you name it. The importance of these complications is not really that you cannot treat them, that you cannot solve them, but they delay the treatment. They delay the radio treatment and chemo, which is not really the thing which we would like to. In 49 patients out of these 94, it was really a serious complication which decreased the Karnofsky scale by 20 points. And 10% complication rate is the highest we have in the whole population of our patients. The only comparable groups are brainstem cavernomas and petroclival meningiomas. In these two, we have 10% of serious morbidity, mortality. And we have this same in gliomas. The reason probably is that we underestimate somehow the gliomas, all of us. It's not really the top surgery, it's nothing really that flashy, nothing really that, say, important. The next thing is that those are teaching cases. Usually the younger people do that, residents. That's another case that we have that high complication rate. And there are several other factors, but probably these two, the psychological, the underestimation of that, okay, I'm done, and the diversity of surgical skill. The mortality was 11 patients, and those were again 2 groups. One of the groups was technical, which were massive postoperative bleeding in the tumor cavity, and the other was the group of patients which I like to call too much too late. Patient coming in a severe neurological condition with a huge tumor, You know from the very beginning that the result will not be optimal, but still you somehow feel compelled to perform surgery. The neurological complications in gliomas is different than in other groups. It's different in high grades and in low grade. The high grade, they have something like 18 months to live. The low grades, you can count it in years. So given the prognosis, the serious post-op deficit in high grades is more or less permanent. The patient doesn't have time to adjust to the deficit and doesn't have time to improve. So despite the fact that we really underestimate the surgeries, we produce deficits which are lifelong, which is probably not the smartest thing. So let's talk about how to avoid it. Surgical indications. Not all gliomas are prone to surgery. Not all gliomas you need biopsy, since MR gives you the diagnosis. It's surgical planning, of course, the performance of surgery, and peri- and postoperative care, which is like in any other. So contraindications for glioma surgery. Of course, there are general. Too old a patient, the patient after several heart failures or whatever like that. Then there are specific, especially in high grades. It's brainstem and corpus callosum involvement. At least this is written in textbooks. Eloquent brain, similarly, in the past, eloquent brain was out of limits. And severe preoperative deficit, which doesn't improve with the steroid treatment. Then there is one complication that you let the patient decide. If you explain the prognosis, if you explain the lengths of treatment, the value of treatment, there is a certain group of patients who really refuse any surgery, including my late father-in-law. The brainstem. This is a case with glioblastoma within the temporal lobe, somewhere where IFOF is and CFOF and whatever FOF you have here in white matter. And going along the motor tract into the brainstem. What we did, we just resected the supratentorial part. We left behind this part of within the mesencephalon, and the patient lived for another 9 months free of any symptoms. So that's probably was the right thing to do. Another one, corpus callosum. We are performing callosotomies as an approach, so why not resect the tumor within the corpus callosum if it's like that, in a tiny part of the corpus callosum? This is after, and again, the patient lived without any deficit for his given time by the tumor. On the other hand, of course, this is not anything for surgery. Who would do biopsy in this case? 1, 2, 2 only. We wouldn't, because in my mind there is no doubt that this is glioblastoma. Do you have any doubt that this is glioblastoma? No. So what is the value of biopsy? Yeah. Again, what does it tell you? Prognosis. Nothing else. You do not get. I think that you do not get any real valuable information. Then, with the advent of radiosurgery, endovascular treatment, and all these other radio treatment, suddenly appeared observation as perfectly legitimate mode of treatment. So this is a case of a young guy, I guess he's something like 30 with seizures. He's having this non-enhancing lesion. So I don't think we would be able to resect the tumor without any deficit. We just follow him, he's on anti-epileptic drugs and he's doing just fine. Another case, this was a lady who came to me in my former department 25 years ago. And when I saw the images, at the time it was CT only, I just gave her a term for surgery. She flatly refused. I'm not going to have any surgery. Some 15 years later, she came to my office in Prague with her son, who has this tumor, which we diagnosed. She just told me, I know I have a tumor, and I would like to know whether my son doesn't have one too. These are MRs of both of them on the same day. The tumor in the mother is still the same, 21 years, and the son, 16 years, We are following this human, never ever done anything. Any doubt that this is a low grade? No one. But this is really an exception. Tumorectomy versus lobectomy. This is another thing which we were talking about. My father was a neurosurgeon. He's 97 now. In 60s, they did lobectomies. They really resected the whole lobe, frontal, temporal, with the tumor. The results were not any different. And what we did in glioblastomas, each decade after the World War II added 1 month on the prognosis. So each decade we are better for 30 days for glioblastomas, which is not really a big achievement. Surgery. How should you perform the surgery? Do not underestimate high grades. It's a general attitude, all right, there is a meningioma, there is this hemangioblastoma, there is cavernoma, whatever, you know, they always somehow, aneurysms, AVMs, always the gliomas are something like a pariah in all departments. And the bosses are not doing them usually. Restricted to the affected gyrus, your approach, as Pablo has shown several times during these 2 days, sulcal approach, vessels are at the depths, remember all those tracts which we have seen. Skull-base approaches whenever necessary, not frequently. Use microscope, of course. There are still places where they do not use microscope for glioma surgery. CUSA is one of the best inventions in neurosurgery. ALA, it really helps a lot. It's better than the intra-op MR because it really shows you the true margin, and intra-op MR especially for low grades. So all these things, and there are a few general rules: large enough craniotomy, tumor on the surface, or as close as possible to the surface. You should plan your approach along the long axis of the tumor, which should be vertical, because then it's comfortable for you. Open dura carefully, correlation between MR and surgical field once you open the dura, and so on and so on. There are many things. Probably the ALA in high grades is the best. This is a nice tumor, so you use this position, you come directly down to the tumor. This is intra-op, this is within 3 days. This is the ALA. In Europe, if you want to use ALA, you have to get the special seminar by the company selling ALA. Have you passed it, both of you? Yeah. And the first thing they prohibit you is to use resection to resect when you are on with ALA. Just the opposite is true. I have a surgical chair where is a pedal, and I just switch on, switch off the ALA resecting the tumor. Probably they would prohibit me to buy another thing. Then what we need to know is that the radical resection is radiological term. It's not biological term. You would call this radical resection? Of course, it's not. There still is some tumor left behind which you do not see, which the ALA doesn't see. So it's really a radiological term, not the biological. Then we may be happy sometimes, even despite the number of complications. Oligodendrogliomas, they should live some 8-10 years after the resection and treatment. But there are exceptional, and I guess that whoever is older here, we all have glioblastomas which surprisingly survive longer time. No one knows why. This lady, I've operated in 2008, and this is the image from 2018, and she is still coming. And I still am not brave to tell her, all right, let's prolong the checkup. So she's coming each 3 months to get her MR. Would you prolong the time, someone here? Nah, no one. So she's coming for 10 years. Each 3 months I'm seeing her, which is much better than to see Hippel-Lindau patient. I am always pissed off when Hippel-Lindau patient comes. Monitoring, of course, we did some studies on that. So whenever there is eloquent tumor, the monitoring is extremely helpful. We've tried to do DTI on intra-op MR, it didn't help much. Awake surgery, that's very nice. Now you avoid complications with the speech, but it's something which is sometimes frustrating, like in this insular glioma patient. Of course, we did it awake because it was on the left. We had this functional MR, which is nice. We just had this GTI. Now we have much better. This is an old image. This is during the surgery with all the stuff you've seen here several times. This is the first intra-op MR. You see the tumor remnant in the back. It's always like that you leave something behind. So we continued surgery. This is the second MR, still some tumor left, especially posteriorly. At the time, the patient was tired, we were tired, so we quit the surgery. This is 1 day after surgery. He has no neurological deficit. Here is the remnant, which is very apparent and which is habitual for insular gliomas. So we went, within a week, we were there again. You see that we resected some. These are bone wax cylinders to get some markers where the tumor is. There is still a little remnant. We did it. This is after the remnant, and this is the final intra-op MR. 2 long surgeries, awake surgeries. This is what we achieved during the second MR. This is first day after the second surgery. We were happy, but still, at the very end, there are some hypodensities which I am not able to evaluate. Our radiologists are unable to evaluate. Only Necmettin Pamir, who is getting the biopsies from these places, claims that he is able to recognize the tumor. This is 3 months, and you see this spot which probably is or is not tumor. Only dynamics will tell. There were some unoptimistic features in his histology, despite the fact that they coined it grade 2. He got radio treatment plus chemo, and this is after the 1 year, the tumor in the whole left hemisphere. We did nothing, of course, at the time, and this is a year after. So despite all these major things, we were unable to save him, we were unable to prolong his life, and this is probably the case in all low-grade gliomas, because you do not know at which time you get them, how long the tumor was there, so the figure of 5 to 8 years is very arbitrary. Okay, so let's make it a little interactive now. This is a young boy of 8 years. He had biopsy elsewhere. I'm not going to tell you what that was. He's got tremor of his right hand. Solve a case.
Let's turn the lights on and wait. Let's turn the lights on and participate with the audience.
You want to remove it? You want to remove it? Yes. Pablo, do you want to remove it? Yeah.
I do. Remove.
Remove. But you are from the same department.
That's why there's a referee.
Yeah. Julius, remove. Eka. Remove. Everybody agrees. You don't agree. You don't agree. You don't agree.
It depends of the biopsy, the result, but it's
Parasitic.
I'm sorry.
Parasitic.
Okay, I will watch.
You will watch. So at least 2 of you. Now the approach. Yeah, sure. Supra infra. Yeah. So it looks like that. What do you want more?
One more vote behind you.
Excuse me, Professor. Could you please use the microphones? Because
Yes.
we cannot, no, for you.
Oh, sorry. Well, you are sitting too much to the back. Why don't you move forward? Can we dim the light? Oh, those were the translators. All right, this is supra-infra, this is the tentorium over here, this is the cerebellum. So what is this vessel and what is this nerve? Not Roy and Pablo and Igor, they know. Chris, you know. Anyone? Yeah. This is the fourth nerve. This is the superior cerebral artery, and this is the tumor over here. And one would expect that the tentorium would need to be cut, but not. You see, this is during the surgery, preserving all the tiny vessels arising from that. This is the end of surgery, cerebral hemisphere. Over here, tentorium and the mesencephalon. And this is after, and this is the boy with tremor disappeared. And since this is pilocytic, I guess he's cured. What about this one? He's 18, headache, diplopia, and paresthesias on the left side.
This is non-operated, right?
What?
It's different from the other.
Different from the other. Again, follow.
No, not again follow. The other it was operated essentially. This is a.
He was only biopsied, the first one. This one not. This one came directly. So what do we deal with? First is what do we deal with, and then the treatment.
Well, it could be a pilocytic again. That's one option, and I would go for it.
You will go for it.
Yeah. Well, I think I would do a contralateral approach, transcallosal, foramen Monroe to the thalamus, contralaterally from the other side.
Through the third ventricle.
Through the third ventricle.
Okay, Pablo.
It seems ventral thalamus, so it means corticospinal tract should be lateral. It should be kept in mind. It would be helpful to have a tractography, but we can guess that. But it's in the axial slice, in the T2, it seems that the corticospinal tract is also pushed anteriorly. So after spending 3 years with you, I think a good idea would be to go from below. Because the thing is that for thalamic lesions, as Roy said, transcallosal is a great option, but this is quite ventral.
Right. Roy, when you come transcallosal, don't you think that you have the tumor to the side and you will not want to see it directly?
Roy, you would choose this?
Yes. Yeah, exactly. I would go from the other side, go transchoroidal. Transchoroidal. So I will not cut the tinea thalami, I will cut the tinea fornicis. So go between the fornix and the choroid plexus of the contralateral hemisphere.
Roy, what about this? You will end up in the third ventricle?
Yes, I'll be in the third ventricle, but
yeah, but
there is I'll go. No, not completely through. There is a place where it is here, quite thin.
Mm-hmm.
I'm hoping that there's not too much tissue there.
Do you think that a supra-infra approach and going from through the pulvinar of thalamus, seeing the lesion direct, could be an option? Yes, of course.
Sure. See this image. You are in the pineal region, and the cyst is reaching the region there. So we don't, no doubt, we all believe that this is a pilocytic. We all believe that it should be treated surgically. Again. So this is the approach. Again, it's tentorium. The cerebral hemisphere is below. But you cut the arachnoid and separate the arachnoid in pineal region is always somewhat difficult because it's dense and you cannot see through and it's really firm. So everything should be done sharply. No tearing arachnoid, very sharply, no wooden spatulas as you were provided with here. Everything sharp. Now it's open, so you see the mesencephalon and we are on the same side as the tumor, Roy, not from the opposite side. We are on the side of the tumor. And this is the lateral aspect of the thalamus. And now it's not high enough to reach the cyst. So what we did is cut a piece of the tentorium, like a V, to get 4 or 5 millimeters higher up. Let's wait a minute. That's it. So it's exactly what Pablo has shown a while ago with the glioma tumor to go through the tentorium. You do not need to open tentorium too much. It really should be always as much as needed or as little as needed. It doesn't matter what. And now we shall see. This is the base of the occipital lobe. All the major vessels are hidden. You do not need to see them. You will hit the only one, which we shall see immediately. It's a little boring to cut the tentorium. And the only thing is to be careful not to get too much to the midline because there is the rectus sinus, but vein of Galen and rectus sinus in this case is quite higher up, another 2 centimeters still. It's not that close. So, bad editing. I'm sorry for that. But you see the thing, and now we are through. We are higher up, and this is the lateral portion of mesencephalon. What this vein should be? How would you call it? What? Rosenthal. Right. And this is one of the major perforators for the brainstem. So this is the field, as Eka has said, tiny opening, and only by blunt enlarging you get in. And the cyst provides exactly the corridor. And if you remember the image, you are directly in line with the tumor, which is at the top of the cyst, just across the cavity. So it's already the tumor. That's it. This is at the end of the surgery. We don't need it. And this is the end. You see how the tentorium is cut. This is the mesencephalon. This is the cerebellum. And this is after. And actually, it's nearly extracerebral approach, getting through to this space when all the white matter crosses. Let's last, again pilocytic, I'll tell you. She is a young girl, she has spasticity of her hand. She was even treated by plastic surgeons, cutting some of the tendons very unsuccessfully. Now we even have DTI, Pablo. She's 24, that means that you want to help her with pilocytic. Pilocytic, similarly as the ependymoma, is the surgical disease. You have no other means of treatment but surgery. Thalamus. Yeah. No one would offer, or
yeah, I would do the same thing as before from the contralateral side.
Like right transcarousal approach.
Like this, yes. Transcarousal, yes. Quite a lot of tissue there.
Well, you enter into the cavity of the third ventricle. You have to get into the transchoroidal into the third ventricle. No, but the medial border of the tumor is in the ventricle.
There is a described approach I don't like too much, which is going through the temporal horn, splitting the choroidal fissure. But the thing is that you will face in the anterior part of that exposure, you will face the cerebral peduncle. Exactly, exactly.
But there is the.
That's in the That's it. That's the trick. That's it. That's the problem with the transchoroidal. Yeah.
Now I agree that with a transcallosal will be a safer approach. There's not a cyst to facilitate the dissection. You need to do a direct approach to the lesion. I agree with the transcallosal, transchoroidal approach to the third ventricle.
So you would go as far as the third ventricle?
Yes. In between the two ion sepal veins.
I have another. Anyone? Any other option? Julius? Here.
I think maybe a front orbital zygomatic and from behind to the peduncle.
Orbital zygomatic, like working for the.
Yes.
Yes.
Through. CA.
That's what it was spinal tract. It's very tough. It will be coming.
But it's really close to the border, to the peduncle.
Basically, you'll have to follow the third nerve. See the third nerve and follow the third nerve to the peduncle. But that's a crazy area to operate. It's a very difficult area to operate. You have to follow the third nerve, all the perforators, posterior communicating. I wouldn't do it. Yeah. Yeah.
Yeah, but that's why he said orbital zygo. Yeah. Not really.
No.
Not really.
Yeah, only for hypothalamus.
To be honest with you, I have sent this case to Ugur Ture. I didn't know either. And what he suggested was going directly from the front and through the lateral ventricle. This is the line he drew for me, so I did it. Transcortical, of course, but it would be probably possible through the corpus callosum as well. And this is after, and she's really doing very well.
Yeah, if it's coming on top of the thalamus, you can approach it directly from the lateral ventricle. And the inferior part of it, if you want to get it, we have to open into the third ventricle and get it. But that's great.
I was thinking along the same lines as you did for quite a long time. It took me nearly a year to tell her, all right, we are going to do surgery, and Ugur suggested that. Should we jump to the conclusion about the complications or another case? Up to you. You tell. She said this 3 short loss of consciousness, but then she's doing well.
So it seems it's inside the third ventricle, causing obstructive hydrocephalus, pushing the Sylvian aqueduct. So it seems extrinsic, or at least exophytic, in the posterior floor of the third ventricle, I would say, which is the tegmentum of the midbrain. So I think a transcallosal approach, splitting the choroidal fissure, would be a good idea in case the veins in the foramen of Monro are good for that.
Behind, posterior to foramen.
Yeah. Transchoroidal, enlarging the.
Yeah, at least it gets you anterior to the tectum. If you do a supra-infra, you may have the tectum, but I don't know if you could.
No. I was considering lateral supra-infra, but I didn't feel, because it's quite low.
Exactly, yeah.
So I did exactly what you said without the with the reservation that this is intra-op from above through the posterior to the there is little piece left. I didn't feel confident to go as far as there, but she's doing well. For those of you, this is CA.
Was that a pillow? Was that a pillow setting?
What?
Was that a pilocytic gastro? Pathology.
Pyrocytic again. I didn't think it will be pyrocytic because they didn't enhance, but it was really pyrocytic. All right, so how to avoid complications? Back to that. The performance should be exactly the same as in those easy and difficult. It should be the same as in meningiomas, with the reservation of those teaching cases. So really, peri and post-op care exactly the same as high-profile patients. 10% complication, it's quite a lot. There is a large space for improvement. And I would suggest you do all this back at home in your departments to check the complication rate. That probably you might be surprised with all those small ones. Small complication which you say, all right, this is nothing that important, but it delays the treatment. So give gliomas the same mental workup as you give meningiomas, AVMs, and patients like that. Don't underestimate them. Perform surgery in the same manner as that of an AVM. Really carefully, very precisely, as good as you can do that. Enjoy it. That's probably the most important. If you enjoy something, you do it much better than the other guy. So if you will enjoy the surgeries of glioblastomas, you will do them better than those who do not like it much, and those are in majority. See the glioma patient in the ward as frequently as you see some high-profile patients. Really don't underestimate anything. This is probably what we really can do for them. Let me finish with the introduction of my country, because we are quite far here. It's directly in the middle of the Europe, surrounded by German-speaking countries. This is the capital. You all know that, but probably you don't know that. It's Prague. It's really a medieval city which never was bombed or caught fire or something, so it's really very nicely preserved. These are the other cities we have. Eka, you would recognize this one, which is Kutná Hora. You've been there. There are others. This is the one I would suggest. So there's lots of medieval things. There are lots of chateaus and castles all over the country. We have snow, very mellow countryside. We do not have high mountains like you do. The highest mountain we have is 1,600 meters, and quite a lot of people live in villages in the rural side. Sports, it's like ice hockey. It's the most popular, probably just second to football, in which we are not good. In ice hockey, we are winning championships quite frequently, and this is the national pastime, skiing. During the winter time, everybody is in the mountains, so we close the hospitals, we close the factories, and everybody is skiing. What we are good at is tennis. This lady won twice Wimbledon. This lady was for quite a long time #1. This guy is for several years within top 10, and then we had Lendl and Navratilova, who were really top players. This is our economy. 40% of industry is automotive. I don't know whether we export them to Bolivia, the Škoda cars. It belongs to Volkswagen. They are in Indonesia, but probably not here. So cars and weapons, we are extremely good at weapons. Whoever comes, we sell it, you know, and probably our best invention is Semtex. During the communist time, all the terrorists were shopping like crazy for that, and it still is in the market. That's a good income, actually. And this is the best feature we have. Not the girls, but the beer. Girls also, of course, but the beer, and sometimes it goes together. And this is the mother of all beers. You see Pilsner, and you call it's like a general name for all the beer. It's not. This is the brewery in Pilsen, where they started doing this, and this is by far the best beer. So this was about the country and economy, and these are the famous people who either lived or worked in Prague. One sportsman, he was able to win 5,000, 10,000 in marathon at one Olympics games in Helsinki. No one ever was able to do the same thing, not even those Kenyan and Ethiopian runners. Franz Kafka, Albert Einstein, Mozart, they all lived and worked in Prague for quite a while. Actually, Kafka was a citizen of Prague. And These two are medical guys whom you know, Chiari with this malformation, and Purkinje with these cells within the cerebellum. They both are from the university I'm now coming from. Okay, thank you.
So that was the last lecture. Thanks for coming. Thanks a lot for the discussion. And also thanks for the faculty for coming and for investing in this course. Richard, would you please come and say some words in Spanish maybe? So we can close the session and close the course, this part of the course. And then we'll see each other in the afternoon and we'll finish there. So most people here we're not going to see anymore, right?
Por favor, ahora nos toca el almuerzo. Andrés, ¿ya está todo listo para transportar a los profesores? Y todos regresan a las 2 de la tarde, por favor, en el auditorio del anfiteatro, a las 2 de la tarde. Anotar su correo electrónico. El correo electrónico que tienen mis asistentes, tienen una lista, hay que anotarse todos, por favor.